Okay, I'm just saying Chitra is looking smart and fresh as ever.
Smart and fresh, yes.
Oh, all big people there.
Yeah.
And you have to say
You are
beautiful.
big yourself.
Yeah, exactly.
Hmm.
Beautiful is tricky.
We are like,
Ramu, Ramu.
Yes. A very good evening to one and all of you here. We are yet back to you with an ARC update on preventing, recognizing, and managing the complications of medical and surgical therapy of glaucoma. So I promise you that in the next 2.5 hours, with the kind of expert panel we have in this session and the great set of speakers, I'm sure you're going to be finding yourself learning a lot more than you had bargained for in the next 2.5 hours. We are truly lucky to have with us Dr. Surinder Singh Panda, who's a professor and head of the Advanced Eye Center at PGI Chandigarh and a very leading glaucomatologist of our country. We have with us Dr. Harsh Kumar, who's the director of the glaucoma services at the Center for Sight Group of Hospitals based at Delhi. Again, a veteran surgeon himself. We are truly lucky to have with us Dr. Davinder Grover, who is a glaucomatologist of great repute, a world-renowned name, and working as one of the glaucoma associates of Texas and specialized in medical and surgical treatment of glaucoma. And we are looking forward to his most impressive keynote address. We are really lucky to have with us Dr. Tanuj Dada, who's a professor of ophthalmology from the very famous RP Center of Ophthalmic Sciences. And we have with us Dr. Vinay Nangia, again, the chairman of Suraj Eye Institute, Nagpur, again, a very senior respected glaucomatologist of our country. We have with us Dr. George Verghese Putran, who is the chief of glaucoma services based at the Arvind Eye Care Systems, Madurai. And he is a person who has brought in a lot of innovations in the field of glaucoma. And moderating with me is Dr. Murlidhar, who's a senior consultant, cataract, glaucoma, pediatrics, strabismus, neuro-ophthalmology, name it, he is all of the Eye Foundation group of hospitals based at Coimbatore. And I'm truly lucky to have him with me. So we shall, without wasting time, go on to our first speaker, Dr. Davinder Grover, who is going to tell us something very, very quintessential, common mistakes in MIGS procedures for the learners and how to avoid and correct them. On to you.
Wonderful. Dr. Chucha, thank you so much for that kind introduction, and thank you all for having me today. It's morning over here, but evening over there, which is such a nice thing to be able to have this exchange, and it's such an honor to present at the All India Ophthalmology Society. So I'm going to talk really just about kind of how to get into this MIGS space and how to avoid some complications if and when you do. These are my disclosures. I do work with a lot of companies in this industry to help with teaching, but these are all my own thoughts and slides. I'm gonna start off with just my general overview of glaucoma surgery, and I talk to my patients about this, but it's also it kind of sets the framework for what we're speaking about. And really, you can either enhance outflow or reduce inflow. And when it comes to enhancing outflow, if the patient has an intact outflow system, then you can do these surgeries that are these angle surgeries, like a GAD or goniotomies or things like that, or the eye stent. And we'll talk a little bit about that. I'm not really going to talk about the other sections of creating new drains, but I think we have a good number of speakers that are going to talk on that. When you're just first starting angle surgery, it's you need to learn angle anatomy. And I finished my glaucoma fellowship, and I started practice probably about 13, 14 years ago. And when I came out of my fellowship, I felt pretty confident. I thought I knew angle anatomy. I thought I knew gonioscopy. And then when I started practicing, I have a gonioprism in every one of my exam lanes. And I do clinical gonioscopy probably 30 to 40 times a day. And I did that, every day for almost 4 or 5 years. And only at that point, 5 years later, did I actually realize how bad I was when I first came out of fellowship. And until you're doing gonioscopy in the office, and you're seeing the thousands and thousands of normal and abnormal anatomy and normal variations, you won't really appreciate angle structures, and you can't do angle surgery unless you understand angle anatomy. And so, and the best way to do that is to practice that in the clinic. And then when you are in the operating room, there's some unique skills to doing intraoperative gonioscopy. And so what I always recommend people trying is, right after you're doing cataract surgery, and you have the lens in the bag and everything, but the eye is still formed with viscoelastic. That's kind of, you're in one of the safest parts of cataract surgery. What I would recommend doing at that point is just looking at the angle. Okay, don't do anything, just look at the angle. So tilt the patient's head away from you, tilt the scope towards you, put on a gonio prism, and just look. The eye is pretty safe. The eye is formed, the lens is in the bag. You're pretty much in the safest part of cataract surgery. You have time to look and just see what it looks like and move the gonio prism around. And then after a few times, then just put your second instrument in the anterior chamber and get a sense of what it feels like to be inside the eye and the depth perception and the tactile feedback. You can do all that without ever doing an angle surgery. And that is such an important preparation to doing angle surgery. And then when it comes to doing angle surgery, I think some of the angle surgeries that are the easier ones to start, or the ones that have a lower threshold for entry, would be things like a tenotogoniotomy, or like a hemi-GAT, or even a GAT, or if you have access to the eye stent or things like that. Those are a little bit, those are angle surgeries that require less manipulation and a great way to get started. Now, I like this picture because it really shows what I do every day, and a couple of things. And I'm going to critique some of my videos that I'm going to show as a point of instruction. But, a couple of things. If you look at this gonio prism, this is a Schwann-Jacob gonio prism. You see there's a little water stain right here. That's just from autoclaving. And so I'm sure you guys don't have this problem with your staff, but sometimes my staff gives me a gonio prism that is not perfectly clean. So you can use you can clean that off, and that'll maximize your view. The other thing you see on this gonio prism is it looks like there's something on it. So on the undersurface, my assistant always will put Helon on the lens itself. And you can also see there's Helon on the cornea. That helps bind and connect the gonio prism with the cornea and minimizes your disruption of view, minimizes air bubbles, and optimizes safety. So those are two things that I always have. You want to, when you make your incision, you want to make sure you don't hit any blood vessels if possible. And if you can't see, come out and reform the anterior chamber. If you can't see, you can't do the surgery, and you need to have a good view. And if you don't have a good view, stop until you get a good view. And then the other barrier is there's so many of these options out there, and sometimes it's kind of overwhelming to know where to start. So I would say just pick one. Pick one. I think, in my mind, one of the most cost-effective surgeries that I'll talk about this a little bit later is like the Tenedo blade, and that's a reusable instrument. You can do it, and just do one and get proficient with that before you try to do other ones. Here's an example of just a GAT. I'm going to show a couple examples of what to do and what not to do. So you can see this is a left eye. There's a temporal incision. I hit some blood vessels and it's bleeding. So don't do that. Okay, don't do what I do. And then you'll see why. So this is a phakic patient, and I'm just going to do a GAT. So I put in some Myocol, some Helon GV. I'm putting in my Prolene suture. And you can see the blood going onto the cornea, right? And watch this, the blood is coming in. It's a nice view. And, I've done thousands of these, so I can get away from that. But this blood is continuing to track onto the cornea and into my view. And I'm doing these little manipulations to get past it, right? But you don't want to have to do that. So next time when you do that, when you're making the incision, make sure you don't hit a blood vessel. And then you can see when I'm coming onto the eye with the gonio prism, there's Helon on the eye, and let me see if I can. There's Helon on the eye, and there's Helon on the gonio prism. That's helping me with my view. So, you know, if you have the option when you're doing your first case, try to do this independent of cataract surgery. If you can do this in a patient that's pseudophakic, then you're not worried about hitting the lens or having to worry about cataract surgery. Again, the difference between these two pictures is your view. And this is true with all anterior segment surgery. The best way to avoid complications in anterior segment surgery is to maintain your chamber. Almost every complication you can get when you're doing anterior segment surgery happens when you lose your chamber. Break the capsule, choroidal hemorrhage, you know, dislocating lens, trauma to the iris, bleeding, all that happens usually when you lose your chamber. And the difference between this view up top and the view down below is I keep the eye formed and pressurized. And if I can't see, I stop. The other thing that's essential that I'm trying to teach more and more every time I talk to anybody about this is having your patient in reverse Trendelenburg. Every surgery I do, this is what my patients look like. And my patients are always in reverse Trendelenburg. And why is that? So when you're in reverse Trendelenburg, you've minimized episcleral venous pressure. You're minimizing your risk for blood reflux. You're minimizing your risk for a choroidal hemorrhage, and it's just safer. And so I don't do every surgery I do, be it cataract surgery, trabeculectomy, Zen, angular surgery, tubes, you name it, suturing lenses, anything that I do in the anterior chamber, in the eye, my patients are always like this. And it's a good habit, and I think it's maximizing safety. This is just what you need to do. You know, don't hunch over and do this. You need to be comfortable, right? And so you need to make sure you're sitting up straight. You rest your hand on the patient. The scope is tilted towards you. The patient's head is away from you. Maintain proper posture. Rest your hands on the patient's face. You don't want to be floating freely. So, and you need to make sure you maintain a proper posture. If you don't, you're going to start having obviously neck and back issues, but it's also hard if you're not comfortable, it's hard to do this surgery. So especially when you're trying something new, it's very easy to just, you know, hunch and get stressed and not be in a good position. So pause, form the eye, get in proper position, shoulders down, head up, sitting up straight, and do the surgery in the most comfortable position for you. The view is so key. Okay, and so there's two types of views. You can have en face and head-on view. So when you have a head-on view, look at this picture down below. If you have a head-on view, you're actually looking down, and you're at risk of actually creating a dialysis, because you're not going to go into the canal, you're going to create a dialysis cleft. You need to look at the angle head-on, not from above. You need to look at it head-on, en face, looking straight at it. And if you're not looking at it straight, you're going to cause complications. And these are some other, if you don't have a good view, these are some things to think about. Do you have blood on the cornea? Is the lens fogged up? Are you pressing too hard? And you have blood reflux. So this is just a video that I put together of just alternating between a good view and a bad view, good view and a bad view. So this is not a good view, right? But you're going to see, even I'm able just to manipulate the eye and push the eye a little bit away from me. And I'm going to turn from a head-on, en face view to an above view, en face view to an above view. And you need to, there's a subtle difference, but that's so key, because that's, again, the way you're going to avoid complications. So this is more head-on, and this is going to be more from the side, en face view. And you can actually, when you do that, you actually see the trabecular meshwork increase in size, because you're looking at it not from an angle, but you're looking at it head on. And it's so essential. It's very subtle, but unless you actually pay attention to looking at it, you want to make sure you're looking at the angle from the side, not from the top. If you're looking top down, you're at risk of creating a dialysis cleft. And so that's a nice side view looking at the entire strip of the trabecular meshwork. So that's kind of an above view, and this is a nice en face view. Very subtle, but it's so key. Don't rush this. You want to make sure you have a good view. So I hope some of you have heard of this Tenedo blade. I'm actually working to create a better version of this that I think are going to provide better outcomes, but I'm not able to talk about that yet. But this is, I think, right now, it's a reusable instrument. You can autoclave it, and it's cost effective, and it's a tremendous way to do a goniotomy. And I think it's been well published. Dr. Tanito from Japan Professor Tanito from Japan has published a lot on this. You know, this is an example of the Tanito blade. And again, there's a left and a right. And in Japan, he's actually starting temporal, and then he's actually going nasal and treating almost 360 degrees. But again, you see there's Helon on the eye. There's Helon on the lens. Let me go to that, pause that. Look at that. So there's Helon on the eye. There's Helon on the lens. And but look at my big fat fingers. That'll block your view. So make sure you back up on the instrument and your fingers are not obstructing your view, especially if you have big hands. And again, you can use this instrument to lift up and get more of an en face view. But you know, have a view at all times. This is actually not the most ideal view. I'm not perfectly en face. I'm looking at a little bit above. But when you've done thousands of these, you can cheat just a little bit and still not cause any problems. But this is not the most ideal view. In truth, I should have a slightly more en face view. And so, but you can create a nice goniotomy. Again, I'm moving my fingers out of the way, and I'm starting on one direction, and then I'm starting on the other direction. And you can see that white strip of the back wall of Schlemm's canal. And this is reusable. So this, in my mind, is a very effective, safe, and cost-effective means of performing angle surgery around the world. And so you can see we published on the wave. Look over here, you'll see some blanching of these vessels as I'm pumping up the eye, proof that the patient has an intact outflow pathway. So when do I not do angle surgery? I don't do angle surgery when the patient needs a pressure in the low teens, if they can't tolerate medications, if they're on blood thinners, if they have very advanced disease and a lot of conjunctival scarring, if they can't limit their activity, if they have an unstable lens, or if they have a lot of broad PAS. But the other thing to remember is when you're trying something new, you know, don't do this alone. You know, you have such a wonderful network that I'm seeing right now of colleagues. And whenever I try anything new, I don't do it alone. I have one of my colleagues that I trust in the operating room with me, sitting on the side scope. So when I'm in the hot seat, they're using their observation and knowledge to help me be better and look at things, especially when I'm trying a new surgery or inventing a surgery. So practice in the wet lab, talk to your colleagues. Every time before I do any surgery that's new, the night before, I sit down at my desk and I draw out every aspect of the surgery I'm going to do, and I write it out and I draw it out and I prepare. Do as much as you can before you're sitting in the hot seat. And then also, you know, I know it's a long trip, but I always have an open door policy in my operating room. If any of you find yourself in the Dallas area or in the US, please let me know, and you're welcome to join me. So I would like to thank you all for your time, and thanks to the All India Ophthalmology Society and Dr. Chitra and Muraladhar, as well as the whole governing council. It's really just appreciate you inviting me and for making this happen. And this is my glaucoma family that I depend on. And this is my YouTube channel, which a lot of these videos are on. So thank you for your time.
Thank you. Thank you so much, Dr. Grover, for giving us such very essential, very basic, but very relevant key pearls. I could have watched your surgeries for some more time. Now, while you beautifully explained the entire angles, the structure, and how the best way to get a good clarity to go ahead with the procedure, but supposing you started passing your suture, how would you detect a suture misdirection?
Yeah, so a couple things. You know, when you're doing GAT, a couple points. So the point where you're most likely to get misdirected is usually the first 90 degrees. So I want there to be a gentle curve in the suture that will help go along the natural curve of the canal, number one. Number two, when you see these videos, and there's some videos on my YouTube channel, I'm going to pass the suture, and then you're going to see me do this. You're going to see my gonial prism move. And actually, as I'm passing, I'm looking, because the point where you're most likely to go misdirected is the first 90 degrees. And once you turn that corner and go the first 90 degrees, you're in a very good spot. And that's a really reassuring situation. And this is just the feel. So as you're passing it, the suture is going to go around, go around, go around. And when you're about 180 degrees, as you're passing it, you should start to feel some resistance. Okay. If you don't feel resistance and you're just doing this and doing this, then you're likely in the wrong place. You're supposed to feel resistance. And if I'm doing this and I'm not feeling resistance, I pause and I look. And sometimes the suture has popped out of the canal, and sometimes it's gone in the suprachoroidal space. The other thing that I do, and this video is also on my YouTube channel, is before I start, I will estimate the circumference of the canal with my suture, and then I'll bend the suture and create a kink. And so I know that if I'm passing it, and I see my suture come around, I should see my kink in the proximal side of the suture. If I don't see the kink, if I see the kink and I don't see my suture, that means I've gone too far and I'm in the wrong place. So there's all these little subtle things you have to constantly pay attention to. When you start to feel the resistance, it's a little bit annoying, but it's a good thing. It means you're in the right place. If it just looks easy, then you're not in the right place.
Murli, would you want to take a question? You have to unmute yourself.
Okay, Chitra, quickly, I just want to ask Dr. Grover,
Yes.
what is the worst complication you have ever had, truly, with this?
With what? With GAT?
Yeah, GAT.
Or with any angle surgery?
No, GAT. Let's go to GAT.
Let me back up. The worst I've ever seen and the worst I've ever had. The worst I've ever seen is a large cyclodialysis cleft. Okay, that's when that person didn't have a good view and they were pretty rough with the angle, and they created a large cyclodialysis cleft and hypotony. The worst I've ever seen, and you have to remember, this was when we first GAT, we've been doing since October of 2011. And so when we first did GAT, we thought it was the most amazing thing, and we thought it was perfect for everybody, and we were doing it in everybody, right? And we didn't have that exclusion criteria. So the worst I've had is when I did GAT on a patient that was on blood thinners and didn't stop their blood thinners, and so then they had a large hyphema. And then the hyphema spilled into the vitreous, and they had a large vitreous hemorrhage, and their vision was hand motion, light perception, and then they needed a vitrectomy, and then they ended up getting a cataract, and then they needed cataract surgery. So we learn from. We learn every day. That's why we call it practice. We practice medicine. Every day we're learning, and we learn from our patients, and we learn from each other. And so that list of exclusion criteria that I have is based on theory, but it's also based on what I've learned when we first started doing this. And when you're doing these surgeries, you need to be an astute observer, and that's how we're learning all these things. So we, a lot of these complications I've had to deal with, and I've learned from, and that's what what's informed my decision-making process on what to do and when not to do it.
Murli?
Yes. Dr. Devendra Grover, thank you so much for joining us. I have a couple of questions. One is, would you do GAT in a patient who has, say, no posterior capsular support, let's say, previously placed lens on a posterior capsular rent or a scleral fixated IOL? Would you do it in those patients? If they require a glaucoma surgery? Yeah,
I don't like to, because, to do GAT, and again, when you've done thousands of GAT, you can get away with it. But that's definitely not your first shouldn't be your first 100 GAT cases. But the problem with GAT is you need to form the anterior chamber quite heavily. And if you don't have a good chamber, you're going to get blood reflux and everything like that. And if you have a lens that's unstable or sclerofixated or iris fixated, you can, and I've had that as well. I've had the lens dislocate. And so then you're at risk of, if you have a hyphema, of a vitreous hemorrhage. And then you have to suture the lens again, and it really adds a lot to the complication. So if I see any kind of pseudophacogenesis or IOL instability, I avoid GAT for two reasons, right? One, you could dislocate the lens, and two, if they have a hyphema, the blood will go into the vitreous, and then they lose their vision, and they might need a vitrectomy.
Is
Have you
there
had
any
any-
role of a excisional goniotomy or a regat if the primary surgery failed?
I'm sorry, say it again.
Is there a role of an excisional goniotomy or a regat if the primary procedure failed in a year's time?
Yeah, we've tried that. We've tried to repeat GAT on a patient that it's failed, or repeat goniotomy, and I have not found it to be that successful. Right. And then you also have to think about, from a patient's perspective, right? If my mom was having surgery and she had a GAT, and then she needed another surgery because it didn't work, and then the surgeon did an excisional goniotomy and that didn't work, and then she needs a third surgery, the family's going to be like, well, what's going on? Fix the problem. Stop operating on my mom. Just fix the problem. So, you have to also think about the patient and the patient's family and the trust and the relationship. And when you start doing more of these surgeries and they don't work, then it starts to erode the relationship. So I haven't found that repeating it works, but we just don't understand why these angle surgeries fail. And they can fail for many reasons, right? You do the goniotomy or the GAT, it could fail because Schlemm's canal is scarred down. It could fail because the collector's system is scarred down, and we don't know. So usually I'll give them one chance at an angle surgery, and if it doesn't work, then I'll do something different.
Dr. Grover, have you had any severe IOP spikes after GAT, especially in the first 1 or 2 weeks, because you fill in some OVD into the anterior chamber? 20%
Yeah.
of OVD fill is vitrectomy.
100%, yeah. And as we reported in our papers of the, you get spikes, and the spikes can be a couple reasons. One, you can get a spike from retained OVD. I actually will intentionally leave OVD in the anterior chamber. Two, if you have a hyphema, sometimes you can have a spike from the hyphema. And then three, you actually can still get a steroid response after GAT. And so in all those cases, actually, the first medication I start back is pilocarpine. And pilocarpine works amazing as the first intervention after GAT when the pressure starts to go up. So yeah, you can get all those. You can get a spike, and thankfully they're not common, but yeah, you can get all that stuff, but they can be managed. And usually with the steroid response, hyphema and OVD, those are all transient. So usually you can treat the patient through that, and then they usually do quite well.
Dr. Purvi, you wanted to ask something?
Yeah, I just wanted to know if the GAT fails for any reason, is there a change in the response to any of the topical MIGS that you would be starting?
No, not really. Not that we've seen. We haven't seen patients be worse off after GAT. If the GAT doesn't work, it's usually because their outflow system was not intact anyway. But we haven't seen patients be worse off. That's one thing that we were always thinking about was, wait a minute, we're opening up the trabecular meshwork. If they get scar tissue and then it shuts down their system, are they worse off? And we haven't seen that. GAT is not a surgery that's never been done before, right? I mean, we've been doing GAT since October of 2011, but GAT is a modification of trabeculotomy. And, trabeculotomy has been done since the 60s. So it's a modification of a surgery that we have, 70 years experience on. And trabeculotomy is still done all over the world, and it has been for the past several decades. It kind of fell out of favor once trabeculectomy started becoming more popular, but you know, GAT it's analogous to an appendectomy versus an open appendectomy. It's just a less invasive way of doing a surgery that has been around for a long time. So our GAT data is not much different than a lot of the trabeculotomy data that has come out of Japan and Germany, and so we're not seeing patients worse off afterwards.
Any other question from others in the expert panel before we go on to our next speaker?
Yes, Dr. Chitra, just a quick question to Robert. I think that's a wonderful lecture. I think very nice tips. I just wondering, I think Dr. Devendra did mention about the collector channels being functional, you know, as a prerequisite for these surgeries, angle surgeries. So do you do any specific tests to, you know, kind of to know that the collector channels are working, or is kind of a clinical impression overall?
Yeah, Dr. Pano, that's a great, wonderful question. That's our dream, right? So we, you know, my partner, Dr. Feldman, and I described in 2012 something that we termed the episcleral venous fluid wave, and that's the blanching that I showed, and that has been closely tied to outcomes. And the better the wave, the higher success of surgery. There's not a preoperative test that we have yet. You know, like the cardiologist, they can do a cardiogram and an angiogram, and they can say, okay, you have a blockage in the LAD, we'll stent that, or, oh, you need bypass graft. You know, we don't have that ability yet. Finally, the cardiologists are doing better than us. But one day, hopefully, we will have what cardiology has is a way to preoperatively assess a patient's outflow capacity and then adjust our surgery based on that. Now, in our 2-year GAT data, there was a connection between stage of glaucoma and outcomes. And in the US, when a patient has a mean deviation on their visual field of worse than -15, their chance of failure after GAT is 90%. Right. And so when I first came to India to do GAT and teach GAT, all the patients they gave me were patients that had mean deviations of worse than -15 and worse than -20. And I was like, okay, great. These surgeries are going to fail. And everybody in India is going to think that that GAT doesn't work. What's interesting, and this is becoming more and more common knowledge too, is that, you know, in the US, a lot of our patients that have advanced disease, they've been on drops for 20 years, right? But in India, the patients that I operated on, they have advanced disease, but they presented advanced. They haven't been on, you know, Cosopt and bromonidine and latanoprost for a decade or 2 decades. They've been on nothing, maybe timolol for 6 weeks, and they have, you know, a mean deviation of -17. And those eyes that you guys see at that point, those are pristine virgin eyes, and they all did really well because their eyes were not abused by the drops the way they are in the US. So I think that makes me even more excited about use of GAT in other countries where patients aren't on drops for decades. And I think there's a tie to that as well. So in India and in South America, I will do GAT in patients that have advanced disease if they haven't been on drops for a long time.
Thank you so much. They were all terrific pearls for learning, and so were the questions. We look forward to seeing you again, or would you stay on for a bit?
I'm gonna pop off, run to my office, and then I'll log back in.
Yes, thank you so much. Thank you.
Okay.
So
All right,
we are going to go on with our next set of talks, and we are going to adhere to the 8 minutes time so that there is some good discussions. Mr. Sunil, I would want you to remind us at 7 minutes so that we could, our speakers could wrap up their talk in the next 1 minute. You're there, Mr. Sunil?
Yes, ma'am. I'll listen. Yes, ma'am.
So we go on to our next speaker, Dr. Sirish Nelbigi, who is the director of the Nelbigi Eye Hospital at Bangalore, with a huge experience in the field of cataract and glaucoma. And he is going to be taking us on to the common adverse reactions of glaucoma medications that should not be ignored. On to you, Dr. Sirish. Dr. Sirish, can you get connected?
No, he's not responding even I've asked to.
He's there on the screen. Okay. Could you call him by the side? I could take on Dr. Kirti Singh if it's not too sudden for her. Thank you. And Dr. Kirti Singh again is a very famous glaucomatologist of our country and has been a teacher for innumerable practicing glaucomatologists all over our country. And she heads the Guru Nanak Eye Center, the glaucoma department at New Delhi. And she is going to tell us something so very important. Dr. Sirish, you can go in as a second speaker because we couldn't get you. And she is going to tell us about the 10 tips to make trabeculectomy safe. On to you, Dr. Kirti. It's truly lovely to have you on our ARC platform.
Thank you, Dr. Chitra. Same here. Thanks for that lovely introduction. So I'm sharing my screen. Is it visible?
Yes.
Okay. So yeah, do stop me at 7 minutes because there are too many tips to ensure Bleb's longevity. So the topic given to me was 10 tips to ensure the Bleb's longevity. Now we all have to remember one basic thing in glaucoma surgery, that the success of glaucoma surgery depends on the incomplete healing, where the aqueous outflow is permitted by the scleral flap into the subconjunctival space. At the same time, we want the conjunctival sutures to heal completely so that the conjunctival incision heals completely. Very often we have this Laurel Hardy situation where for the Laurel side, you have a shallow AC, low IOP. It could be due to Bleb leak or a choroidal detachment. In those scenarios, you'll have a poor Bleb, or it could be due to an overfiltering Bleb. On the other hand, the Hardy situation is where you have a high IOP, deep anterior chamber. It could be tight sutures. Again, the Bleb would be poor. So to prevent all that, these problems, the first step is use of releasable sutures. And there are many ways of using releasable sutures. But I use either the Cohen-Osher technique or the Wilson's. Wilson's causes more of suture-induced surgical astigmatism, whereas Cohen-Osher causes less of it. So this is a modified Cohen-Osher technique. We have not used the Kolker's modification in this. And it's a single suture. It's a 10-0 nylon suture, which is taken from the scleral side, from the cornea. This will be exposed in the cornea, and the loop is created in the scleral flap. And you have 4 ties coming there, 4 rows. Now comes the very important step. From the side port which we have created, you do a checking or a Bleb titration. And you see how much the flow is there. Here I'm finding that the flow is a little excessive. So I'm giving a fixed suture. I could have also given a releasable suture here. So it depends on that time what you are finding, what the stage of glaucoma is, what is the compliance of the patient, and what the conjunctival health is. And this is the technique which we have started in our center for the last 5-6 years, is the frill incision of suturing. Now, this releasable sutures gives us controlled egress of aqueous, yet not a free flow. So it prevents hypotony, which is the nightmare of most glaucomatologists. And to release the sutures, this is the Wilson's technique of releasables. It's released on the slit lamp, and you do it usually within 2 weeks, or when the IOP is high, and when the Bleb height is less. In the initial phases, go more on the Bleb height. Do not wait for the IOP to increase before releasing the releasables. So that was the tip 1. Tip 2 is, like for all good fairy stories, you have the princess and the pea story. And in the glaucoma surgery or trabeculectomy or even tube shunt, the princess is the conjunctiva. It requires a lot of tender, loving care. You must use the touch. You touch the conjunctiva with the non-tooth forceps. Use blunt dissection. Use the safe technique, Moorfield safe technique of MMC, where you push in the sponges in the periphery and little bit away so that the MMC doesn't come in contact with the cut edge. And most of these patients, when they come to us, they have had a at least 2-3 years, maybe even 5-6 years of anti-glaucoma medication use, and they all have subclinical inflammation. They have the potential for subconjunctival fibrosis, which is the nemesis of trabeculectomy. So conjunctiva has to be handled really, really gently. That's tip 2. Tip 3 is the conjunctival closure, because that's important. As I said, for trabeculectomy, you want a complete conjunctival healing. At the same time, do not wish to have a complete scleral flap healing. And most of these sutures, either the limbus-based or the phonics-based sutures, give rise to some astigmatism, give rise to tear film deformation, tear film disruption, and they give rise to patient discomfort. So this frail incision, 1.5 mm from the limbus, with this 8O nylon round body, this continuous suturing is the one devised by us, and this is very easily removed on the slit lamp. Again, 2 to 3 weeks, usually 3 weeks plus. Once the healing is complete, you just remove the suture on the slit lamp. So this technique of ours is being used by many other people. These are the good blebs seen with this technique of smile or the conjunctival frail incision. The fourth tip is, often you have little loose suturing or you have tight suturing. Now, how to be in the balance? You want the Goldilocks zone of being just right, and the method is titration. If you remember, in the first video also had shown titration. So this is another conjunctival anchoring suturing technique where you have 2 wing sutures and you have a mattress suture. This is nylon. You can also have Vicryl. I prefer always nylon because Vicryl gives way very fast. And now at the end of the suturing, you do a titration to see whether the bleb is formed and there is no leak. So this will ensure your sutures are neither tight or close. This has been circumvented by us by using the frill incision. But if very often we need to use this, especially for the resurgery, and this titration is important. Now, the 5th tip is, very often in glaucoma, unlike cataract surgery, who go home very happy, or even the refractive surgeons, glaucoma people are pessimistic because they know at some time in life the trab may fail, because ultimately it is subconch fibrosis, which is the way nature heals. So again, tell the patient initially to always do bleb massage. This technique has to be explained to the patient or to the caregiver. It will work beautifully in the first 2-3 weeks to first 4 weeks. Beyond that, it doesn't really work well because the fibrosis already has happened and the healing has happened. But in the initial phase, if you do it, the aqueous is the best antifibrotic. So if aqueous keeps coming, the bleb will last long. And as I said before, the suture removal, you sequentially release the first and the second sutures in 2 sittings. I do not release both the sutures together if I have to, and I do it at the gap of at least 5 days or 3 days. The next thing is that you have a failing bleb. You must learn to look for the signs: tenon cyst, walling off of the bleb, reduction in the bleb height or extent, increased corkscrewing or straightening of the vessels. IOP may or may not be raised. So whenever you have any of these signs, do go ahead and do a needling procedure. Before doing needling, always do gonioscopy to check whether the internal ostium is closed or not, because that will require a different procedure, which is an internal revision of the bleb. Here, the thick iris, which all Indians do have, is swept away from the ostium. It was blocking the ostium.
7 minutes.
Ab interno procedure. 7 minutes done. Okay, ab interno procedure. And you hydrate the entry port, and then you do a needling with 5-FU or mitomycin C, depending on what drug you're using. And you, at the end, you close this area with a viscoelastic. You cut the fibrotic bands with the motions of the sideway motions, and this blocked colostomy opens up and the bleb survives. Advanced glaucoma and macular split, you have problems of high IOP, you have a risk of hypotony, aqueous misdirection, ocular decompression, retinopathy, snuff out. The precautions are always lower the IOP with mannitol or Diamox. Monitor the blood pressure. You can do a paracentesis 30 minutes prior. wait for the pressure to lower down, but at the same time avoid hypotony. So the technique for doing all this is use a pre-placed suture. As the side port creation, do a very slow decompression, count till 10. Always use releasable sutures, do a Bleb titration so that you avoid hypotony. The eighth tip is for, again, high IOP not controlled despite maximal medical therapy, including mannitol. We have done successfully diode laser cyclophotocoagulation. For uncontrolled glaucoma, wait for 1 to 2 weeks. The IOP reduction is there. Once the eye is quiet, after 4 to 6 weeks, do a trabeculectomy in a quieter milieu. Then never be hesitant to do a combined surgery, because if IOP control requires more than 3 medications or there are adherence issues with poor patient profile or access to healthcare, knowing that TRAB alone will accelerate cataract. For the cost saving and quality of life, knowing that many of our patients come from the rural area where they don't have access, combined surgery should be attempted. The last tip is trabeculectomy when you do in the presence of minimal cataract, because we have a geriatric population and we know that trabeculectomy increases the risk of cataract by 78%, and explain that this patient will need a second surgery. Otherwise, they'll say, you operated me, therefore I need a second surgery. Second, always have the consent form for visual consolidation, not gain. Often, there may be a one-line drop initially, which will come back after suture removal, but do put that in the consent. Also, tell them that they would require a lifetime of follow-up. I tell my patients, you and me are going to be friends for a lifetime, because glaucoma is a disease which will require our friendship, because trabeculectomy effect may wane over time. We may need to repeat the surgery. We may need medication. So this consent form is very important for your survival, because trabeculectomy would sometimes fail. So the road to trabeculectomy journey is full of turns and bends. So if you have to circumvent these bends, this is the AIOS series of glaucoma surgery tips for glaucoma surgery. It's all available online. You can read that. So thank you very much for that opportunity. I'm stopping the sharing.
That was a wonderful, crisp talk, Dr. Kirti.
Thank you.
You did nearly tell us all the answers in your talk, that if there is a high opening pressure, you would consider giving mannitol and Timox or glycerol. But when would you think of doing a decompressive vitrectomy?
That would be done in a very shallow AC, and that's usually there in angle closure glaucoma where the lens bulge is there. In those situations, I would do it vitrectomy. I would not do a vitrectomy. Actually, I'll just do from the pars plana. I'll do a vitreous tap. And usually these patients, because they have a lens bulge, I would go ahead with the phacotrabeculectomy, because even post-operatively, just with a clean trab, they may have a shallow AC. So most of these patients would require a combined surgery.
Yeah, even if it is a clear lens, would you knock it off?
No, not the clear lens, of course, but very rarely have I seen a clear lens in these situations. I am not at all proposing ever to follow the Eagle study. I'm not a proponent of that. Clear lens is always better left alone unless it is the culprit.
Dr. Tanuj, what are your take on doing a trabeculectomy in a severe ocular surface disease status?
Thank you, Dr. Chitra. So I think you have to grade the severity of the disease by doing a Shermer and a tear breakup time. In early to moderate cases, you can still go ahead with a trabeculectomy. But if it's a very severe disease with no tear secretion, then it is bound to fail. And then the only option for you is to either have a posterior drainage with a drainage device or do some cyclodestructive procedure. And just one thing I would like to add, Dr. Kirti Madam has covered very nicely important tips for trabeculectomy. Just two things I wanted to add. Preoperatively, we have started using steroids because the conjunctiva is so inflamed in many of our patients on multiple medications. So we give soromethylone at least QID for 2 weeks prior to surgery. And to prevent drastic complications, some of the one-eyed patient with very narrow field, we leave some Helon in the anterior chamber.
We do the same thing. We don't leave Helon, we use
rubs the eye or
viscoelastic.
massages the eye.
Yeah.
So any viscoelastic can be left at the end of surgery. That is just a small safeguard. So sometimes you get a situation where you get a hemorrhage due to hypotony or suprachoroidal hemorrhage, then you get very difficult situation. So that is what I just wanted to add. Thank you.
Totally agree with that. I always leave when I do the Bleb titration. If I'm finding, actually we start atropine drops on table. If the AC is forming on table, fine. Otherwise, we do leave a little bit of viscoelastic, not Helon, but I used a methyl cellulose. And yes, we've started using Lotisol, not the steroid, because I don't know how many will be steroid responders, but we do use it 5 to 6 days for the patients who are on a lot of anti-glaucoma medications. Thank you. Yeah.
Would you take some of these patients with the medications if they are in an advanced disease? With just starting with the topical steroids? No.
Are you asking me something? Would
Yeah.
I take what patients?
Well, the patient is still on those anti-glaucoma. You are concerned about taking them off.
We normally, madam, wherever possible, we stop the PG analogs before. I know many people don't stop, but I try to stop it 5 to 7 days prior. And I do use Lotisol now. Recently, I've started because we had this study where we shown that conjunctival lymphocytes are increased, T lymphocytes, but we may not be able to take them off the medication. So what we do is we substitute Dimox instead, acetazolamide. Wherever possible, we try to reduce the medications and give Dimox to supplement and reduce the topical ones. But especially PG, we will stop.
Yeah. Paucity of time, I'll go on to the next speaker. Thanks a lot, Dr. Kirti. Dr. Sirish, we had already introduced you, so you could straight away talk here, start your talk.
Yeah, sorry for being missed out the previous time. Can you see my presentation, ma'am?
Yes.
I think it's full screen. Am I right? Yeah, I think now it's full screen. Thank you so much, Chairman ARC and the members of ARC and the AIOS for having me here.
Sorry to interrupt, Doctor. Can you please make it full screen? It is not full screen as of now.
I have done full screen here.
You can stop and reshare. I think it's
okay.
stuck.
I'll do the end show. I'm redoing it. Did it come now?
You could stop sharing and share again. Yeah.
I could stop sharing and share again. Okay.
Perfect, sir.
Okay, thank you. Due to paucity of time, I'm going to strictly speak to the topic that's been allotted to me without going too much around the topic. So I'm going to talk about the common adverse reactions of glaucoma medications that we cannot ignore. So I'm going to be hardcore on the topics which need to be there. Yeah, let me start with the beta blockers. So we have the beta 1 and beta 2 non-selective blockers, which are timolol, levobinolol. Levobinolol is sparingly available as beta-gan now. Beta 1 selective, we have betaxolol, betaxolol, which is not so commonly available. We have Glucoptec and Beta-Press here. So on the cardiovascular system, it has the maximum effect. Therefore, I would want to stress upon these. These really cannot be ignored. These are the most important side effects of the beta blockers, which we need to really highlight both to our patients and to ourselves. Hypotension is one of them, decreased cardiac output and bradycardia, especially the resting pulse. When the patient is at a resting phase, the bradycardia can be quite marked. So what this also means is resting phase is when we are asleep. So if therefore it is commonly advisable that if you are going to take the timolol as the bedtime dosage, you need to give at least 2 to 3 hours before the patient goes to bed, as the highest amount of bradycardia happens during the resting phase. AV blocks where there is a conduction defect where it can affect the heart rates are actually contraindications. So are also decompensated heart failures and of course bradycardia, as I already told you. Severe bradycardia can happen and even complete heart block also has been reported, though these are less severe. Usually symptoms are reversible after stopping the medications. I'm talking about the heartbeat slowing. But in severe cases where there is a heart block and then we have worsened the case, the pacemakers will need to be needed. This also means that patients who are on pacemakers may not actually be facing the side effects of the beta blockers. It may not be a good choice in patients with heart rate of less than 60 beats per minute or a systolic BP of less than 90 millimeter per mercury. This is not rule of the thing. This is an approximate estimate which I'm giving, which we can use in a clinical practice. On the respiratory system, the important thing that we cannot ignore is shortness of breath. So here we need to exercise caution in patients with respiratory problems like COPD or asthma, where respiratory rate is quite important, and lowering of the respiratory rate can cause significant decrease of the oxygen for the patient. On the CNS, these are a bit less stronger and less common, but then nevertheless important ones. Confusion, fatigue, drowsiness can happen. Patient can have lethargy, sleep disorders, nightmares. Basically, any CNS effect causes, it's like, causing depressive modes, depression of the CNS system. These are seen. Hallucinations also are seen, though not very common. This is due to the beta receptors, which are centrally located in the brain, and then these also get blocked, and hence we see these symptoms. Fortunately, even these symptoms, they are reversible on stopping medications. So if you saw the the CVS heart rate is reversible, and even the CNS ones are reversible. So is the respiratory rate, but then it takes a longer time for the reversal to happen. This is a very interesting study which was published. In fact, this study, simple tabulated form, what you are seeing, has taken into account nearly about 30,000 patients. So their finding is quite interesting. What they say is, this is probably something like a meta-analysis where they have studied a lot of them. What they say is fatigue is the most commonly side effect seen due to beta blockers, and the effect of depression, somnolence, appetite loss, memory loss, loss of libido, and nervousness, they have not been strongly associated. Whatever studies that have been published now either have been industry driven or have been bias studies, or with a lot of improper studies or study criteria which have been involved. This is a recently published one in 2021 in this hypertension by American Heart Association. Am I still on?
No, just till the last.
Hello. Yeah, can you hear me?
Yes, Sirish, I can hear you, and
Yeah.
I can also see your.
Yeah, the slide went for a moment, so therefore I wanted to verify. Possibly more frequent during beta blocker use are insomnia, dreams, and sleep disorders. These are relatively seen. So the most frequent one is fatigue, which is definitely linked to beta blockers. Insomnia, dreams, and sleep disorders are possibly related. These have been found to have probably no effect due to beta blockers, and anxiety possibly less frequent during beta blockers use. Other things also seen, but much rarer, reports of sexual dysfunction, slight adverse effect on blood lipoproteins, hypoglycemia in patients with diabetes, and masking of thyrotoxicosis. So masking of diabetes and thyrotoxicosis. Coming to the alpha-2 agonists, topical symptoms are quite common. We cannot ignore them because quite a lot of discontinuation of alpha agonists happen because of the topical symptoms which come here. Follicular, it is shown commonly as follicular reaction. It can either be acute follicular conjunctivitis, which starts in 6 to 9 months of initiating treatment, and 5 to 9 patients have it. Delayed follicular reaction is seen far more common. Almost between 30 to 50% of people have it, and indicates a type 4 hypersensitivity, and is seen something like this. This is a very common reason where patients get misdiagnosed as viral conjunctivitis or some other allergic conjunctivitis, and they don't attribute it to alpha-2 agonists. This is one important thing which I want to highlight here. CNS effects again are not to be ignored. Molecule being lipophilic crosses the BBB easily. These things cause lethargy, apnea, hypotension, bradycardia, and children are more prone for it. Coming to the less common ones, granulomatous uveitis, which again stops on cessation, very rare. Even rarer is ocular lichen planus, and topical cyclosporin can help here.
7 minutes.
Sorry?
7 minutes are up.
Oh,
1
okay.
minute.
The CVS, some have shown a decrease in systolic and blood pressure and heart rate also, and lowering of BP is something I want to really highlight here. I've had a patient of mine who had a immediate ICU admission because of lowering of the blood pressure. MAO inhibitors have to be avoided during use of this, and young children below 12 years, better to leave them alone from using this. In carbonic anhydrase inhibitors, you have the oral ones which cause metabolic acidosis, hypokalemia, loss of libido, depression. The drug interactions, I want to highlight aspirin. Do not use along with aspirin as it can aggravate the metabolic acidosis and breathing. Blood sugar changes can happen. Be careful in diabetics, and electrolyte changes can happen. So be careful in kidney diseases. So boxed warning of the FDA was giving a huge list of contraindications, but the recent list of contraindications are only these three: sickle cell anemia, renal failure, and Addison's disease. Pregnancy, I have a later small thing which is coming up, so I'll show that to you. Rho kinase inhibitors, I want to highlight just about three things. One is the bleed on the limbus, which are quite common, and bleeds are due to relaxation of smooth muscles and dilatation of blood vessels. Second, I want to highlight is the reticulus bullous epithelial edema, called as corneal honeycombing. These usually happen 2 to 4 weeks after starting therapy, but these we have to be very careful because sometimes the visual acuity decline can be permanent because of this. Cornea verticillata is another one. Again, about 9 to 15% of patients have it, but once we stop it, 12 to 14 weeks, it goes away. This doesn't affect the vision much, but then we need to be vigilant about it. Lot of discontinuation of medications happen because of mebominitis and blepharitis, and this is one important thing which cannot be ignored. And when the patient complains, this indicates the intolerance of medication, and commonly we'll have to stop the medications because of this, and we need to listen to the patients. Pilocarpine, as you know, it's pupil constriction induced myopia, accommodative spasm, and RD is what we already know. Irises are less common. So here I would basically want to highlight these three things, and these shouldn't be ignored. Induced myopia, headache, accommodative spasm, especially something like brow ache is what the patient will complain of, even in accommodative spasm, which causes blurred vision, and RD. Frequency of use is a big problem here. PG analogs, of course, they are relatively quite safe. So long eyelashes, and you can see the difference in the pupil color. These are common. So cystoid macular edema is quite a common thing which is seen with these patients, and I want to highlight this. So this is one important thing which can cause vision loss. And upper respiratory infection, nasopharyngitis, and headaches are sometimes and rarely seen. I have had a patient with low backache where the backache got really more severe after PG analogs. Mannitol, nausea, vomiting, and cardiovascular overloads, and pulmonary edema. These are important things. So here with mannitol, you need to see the CBC, renal and hepatic function, and electrolytes have to be monitored. So to end with, this is my last slide. I'm sorry for overshooting my time. So this I thought is very important. Therefore, I don't want to skip this. In pregnancy, first trimester, the first line of drug can be brimonidine. The second trimester also it can be brimonidine. Late pregnancy and lactation, pilocarpine and brinzolamide can be used. Second line of drug, brinzolamide and timolol maleate. And in the next trimester, again, brinzolamide and timolol maleate and PG analogs also can be used here. PG analogs in late pregnancy may not be the first line of choice, as they can cause a uterine contraction here. Better to, in the last trimester of pregnancy, better to avoid brimonidine. In the first trimester of pregnancy, avoid carbonic anhydrase inhibitors and PG analogs and pilocarpine. Thank you so much for patient listening.
That was a very thorough talk, Dr. Sirish. I mean, wonderful. Yes. Any questions the expert panel would like to ask? Murli, would you want to take a question before we move on to our next speaker? Because I think he's really covered most of it.
Yeah, madam, I have a question for the panel. That is, how effective is topical beta blocker on a patient who is already on a systemic beta blocker? Some of them may be taking for hypertension or for some other migraine or some other indication. So is it worthwhile adding a topical beta blocker should the patient need an anti-glaucoma medication? And second is, if the patient is already on topical carbonic anhydrase inhibitors and the IOP is very high, would adding in a systemic CI help in any way? So these are the two questions that I have.
Yes.
So can I answer that actually?
Yes, Dr. Nanya.
So, I'm just going by the experience. Unfortunately, I don't have any data to back up, but, if you're using a topical carbonic anhydrase inhibitor, let's say that your topical carbonic anhydrase inhibitor is the third line of medication, actually, in which case its pressure reducing efficacy will be only marginal. So if you still want to continue topical carbonic anhydrase inhibitors, please do try to give Diamox actually. We have been using since the past, I think now 30 years, half tablet of Diamox twice a day actually. And for long periods of time in patients that come in different situations. And it does have an additive effect actually. And going to the use of topical beta blockers, yes, topical beta blockers will have an effect even if a patient is on systemic beta blockers actually.
Yes.
Sirish, wonderfully covered in the time given to you. Just one point I want to add specifically for the people who are listening, and that is that especially in children, because the parents will never be very sure how much drops they have put, they'll keep putting the drops. And many times these kids can even go into chain stroke breathing, and the pediatrician will never understand that what has happened because they never correlate. So the punctal occlusion part is very, very important. And I think one should really argue that maybe even OD dose in beta blockers is actually as good as the BD dose. And in children, you can make a 0.25% solution.
Yeah, I think the punctal occlusion part is extremely important for all the drugs across. We usually sometimes tend to overlook the importance of it or don't advise it to the patient properly. I think we should make a very specific point because whatever, sometimes though the side effects are very uncommon, the systemic side effects, but sometimes when we see, we do not correlate it to them. That is the problem. Therefore, as a safety precaution, punctal occlusion helps a lot. Thank you, sir.
Aside of a bradycardia or a cardiac failure, in a cardiac patient, would you think of giving a beta blocker, topical beta blocker?
Aside, other than bradycardia, any other cardiac condition?
Failure. And a
cardiac failure. Yeah, cardiac failure also, it is a contraindication because once the heartbeat comes down, even the pumping mechanism, or if it comes down, then it's adverse effect by itself. It can cause a atrial fibrillation.
Anything else? Shall we go on to our next talk then? We go on to Dr. Sati Devi, who again is heads the glaucoma department at Narayan Netralaya, Bangalore, and she's going to take us on to another important topic: common Bleb challenges immediately post trabeculectomy. On to you, Dr. Sati. I think you need to unmute yourself.
Dr. Sati, please unmute. Yeah.
Yeah. Am I audible now?
Yeah, you will start from the beginning.
Yeah.
Yeah. So I'll be talking about common Bleb challenges that one sees following a trabeculectomy. So the three commonly encountered situations are a leaking Bleb, or overfiltering Bleb, and a scarring Bleb. We'll try to look at identifying each of these, management, and how we could prevent this problem. So the most important sign in a leaking Bleb is the Seidels positive test that one has to carefully look for and not miss this. There is a shallow Bleb, which may show signs of scarring. A shallow anterior chamber may be seen. One may see folds at the posterior pole due to hypotony, and if it is severe, choroidal detachment. How do we prevent this? A judicious and a careful use of mitomycin where you avoid contact with the edges of the conjunctival flap and ensure that you wash thoroughly if you're using sponges. Very gentle handling of the conjunctiva during surgery. Use non-tooth forceps, use blunt dissection, and avoid causing buttonholes. And if you do, make sure you carefully close them. Whatever technique that may be used, be it a phonics-based or a limbus-based flap, in a limbus-based, you can always do a 2-layer suturing, one of the tenons and of the conjunctiva, and so the chances for leak are extremely low. However, it is more common in a phonics-based flap. But whatever technique is used, we need to ensure watertight closure of the conjunctiva on the table. Check with the fluorescent strip on table to avoid coming back to the theater again. Now, if you do notice a leak, what would one do? A bandage contact lens can be placed to facilitate epithelial migration and act as a tamponade. Reduce the topical steroids to promote healing. Aqueous suppressants. You can use cycloplegics that would help in AC deepening. And gentamicin would cause conjunctival inflammation and stimulate wound healing. Oral doxycycline also helps in healing. Most cases do settle with conservative management. However, sometimes surgical intervention would be required. So when would we need to resuture? If one notices that there is a risk of Bleb failure, or if you see a very brisk persistent leak which shows no sign of reducing, and this would also, of course, place the eye at high risk of infection. In this situation, we would like to take the patient back to theater and close the leak. If this is left without managing, you can have the risk of peripheral anterior synechia formation. The cornea can decompensate, cataract can form, or you could have hypotonous maculopathy. Now, if you see kissing choroidals or if you see lens cornea touch, that's an indication for emergency taking up surgical intervention. The next situation is an overfiltering bleb. Here one would see a shallow anterior chamber again, a low intraocular pressure, and one could see peripheral choroidal detachment. But what is different here is that the bleb is a large diffuse bleb, and there would be no leak in this situation. Now it's critical for us to differentiate between the two, though both situations have low IOP and shallow anterior chambers, because the management of the two conditions is totally different. Now, how do we prevent? On table during surgery, ensure that the anterior chamber is well formed. You should have an adequate thickness of the scleral flap itself, adequate cover of the stoma. So on either side of your stoma, there should be adequate cover by the scleral flap. Your scleral flap suture should be sufficient as well as sufficiently tight. Avoid flap tears, disinsertions, or buttonholes, and use adjustable and releasable sutures that help in titrating the intraocular pressure postoperatively. Make sure that you don't remove these sutures too early. Check for filtration or the egress of aqueous once the flap is sutured, and this will tell us whether there is excessive flow, in which situation additional sutures can be placed. Instill cycloplegic at the end of surgery. Now, if you do notice overfiltration, one could put a tight pressure bandage. So you put a torpedo-shaped bandage over the area of filtration to prevent filtration, which allows the pressure to build up. The anterior chamber can deepen, and this takes off the vicious cycle and helps in the management. Frequent topical steroids and cycloplegics can be used. Again, a vast majority resolve with conservative management. A few would require surgical intervention where you need to go in and resuture the scleral flap. If there is a tear of the scleral flap, one may need to put a patch graft. If the bleb is seen to be scarring, one notices that there is high intraocular pressure. The bleb is likely to be flat, vascular, but there is no leak, and the anterior chamber is deep. So this suggests a resistance to the aqueous egress through the surgical site. Now, what would this be due to? Two reasons. One, it would be a sclerostomy that is getting blocked, and this block can happen due to heel, fibrin, iris, or vitreous. Or there could be tight scleral sutures. There may be blood or fibrin under the scleral flap or a large subconjunctival hemorrhage that is inciting inflammation and scarring. There may be retained viscoelastic steroid response, bleb encapsulation. These are a little uncommon. Now, how do we prevent? To ensure stoma patency on the table, make sure that if you do notice vitreous, you need to clear it. Either blood or iris, make sure that it does not block your stoma. Make sure that your Peripheral iridectomy is broad-based and it's not very small. Your stoma should not be very small. Ensure adequate egress of aqueous on the table. Use releasable or adjustable sutures. And in patients with glaucoma intolerance, as has been just now discussed, where you notice conjunctival inflammation, give a course of topical steroids preoperatively. If visco was used during surgery, ensure that there is a thorough wash. Now, if you do notice that there's a blocked stoma, the blood, usually there's a spontaneous resolution in 24 to 72 hours. If not, intracameral TPA can be used, that is tissue plasminogen activator. Fibrin, if it is blocking the stoma, aggressive topical or systemic steroids may be required. Again, intracameral TPA would help. In the presence of iris incarceration, Pilocar or argon laser may not help that much, and a surgical release is often required. If there's vitreous plugging the stoma, a YAG vitrolisis, if it's a single strand, might help. If not, surgical revision would be necessary. If the stoma is patent and if the pressures are high, digital massage would help. If you have used releasable sutures, they can be removed, or laser suture lysis can be tried. Subconjunctival 5-FU injections can be given to reduce the scarring. If steroid response is suspected, you can taper the steroids or use a milder steroid. If you have used visco and you think there's visco in the anterior chamber, you could wait for it to get drained off. Since there's a stoma, it most likely would get drained. However, if it's persisting, a wash would be necessary. If you notice Bleb encapsulation, medical therapy would be started, and this usually improves function within a few months. Now, this patient, you can see that the Bleb here is a little vascular and appearing flat. So I'm taking off the releasable here. And once the releasable is pulled out, the Bleb has elevated. Sometimes there's a spontaneous elevation of the Bleb. Sometimes you would need to do a little bit of digital massage. Now, this patient was an outstation patient who did not come back for the two weeks review, and he came back at the end of 5 weeks with a Bleb that looked like this. So I had to go in and do a needling. This is on day 1 post needling. You can see a Bleb that is formed. There's a subconjunctival hemorrhage there. By 1 month, you can see a good Bleb with well-controlled intraocular pressures. So I'd like to conclude by saying that complications that affect the Bleb are fairly common in the postoperative period after a trabeculectomy, but they're mostly transient and a majority respond well to conservative management. Prompt recognition of the condition, assessing the etiology, appropriate timely management help in preserving vision and Bleb function. Thank you.
Thank you, Dr. Sati. That was again another wonderful talk. I'm going to take just 2 basic questions and I'll ask Murli to take the rest. Now, does it mean that we routinely do check for Bleb leak immediate post-op, Dr. Harsh? For all patients?
Yeah, in the first thing, if the chamber is well formed and your Bleb is nice and flat, shallow, it's not very, then you know that even if there's a mild leak, you're not really bothered that much. It's only when the chambers start becoming shallow that you really need to look where the leak is coming from. And Sati has so nicely said that you can always use a contact lens over there. That really works wonders over there.
How long would you leave it? And would you call these patients every week to check on them? Or would you leave it for 2-3 weeks?
No, I'm too conservative. I call them every alternate day. But I am a little hyper. So I think, yes, maybe 3-4 days should be good enough for that. And just one point I want to emphasize that I think Kirti also said that, but I would beg to differ because the Bleb massage sometimes works very, very well for a very long time. And I read it also. And then there are patients who do it for a long, long time and they keep okay. So we must emphasize.
Yes, true.
Actually, in the post-operative period, and every time that the patient comes, we always check the pressure. So when we apply fluorescent to check the pressure, just make it a habit to look for the sedals before you actually go on to check the GAT. So that way you're always routinely checking for the sedals also.
I think what Harsh said about the Bleb massage, I agree with him. I have, many patients who come to me, sometimes they're doing very well, but they'll come back, okay, do I need a Bleb massage? Because I've been doing them, for a long time. So, sometimes it's like a physiotherapy of the Bleb. So you have a Bleb which is trying to get localized and you just spread it out.
Yeah.
And that happens, 3 months down the line, 6 months down the line, and even longer. So I think even on a long-term basis, there is some role for the Bleb massage. And of course, the purpose of doing it in the early period is different, and yet, doing it in the late massage is different. But I think that actually plays a very important role in the early period as well as in the late course of the period.
Thank you. Any other questions? Should we go on to our next speaker? Okay, we have our next speaker, Dr. Mayuri Kamar, who's again a senior, very respected glaucomatologist, working at Akura Eye and Research Center at Ahmedabad, with a huge experience in the field of glaucoma. And she's going to take on a challenging topic, managing hypotony and shallow anterior chambers after trabeculectomy. On to you, Dr. Mayuri.
Okay, is it visible now?
Yes, yes.
Okay, thank you, Chitra. I will be talking on the managing hypotony and shallow anterior chamber after trabeculectomy. Part of it's been covered by Sati. Trabeculectomy provides us a non-physiological route of aqueous outflow, and the complication may occur despite of the best effort that has been talked about just now. But timely detection and management of this complication is very vital for the good surgical outcome. The hypotony and flat anterior chamber or shallow chambers are frequent and significant complications that can develop after the trabeculectomy. I would like to quote this study, which is a national survey of trabeculectomy, and large cohort has been there. And they have found that about 23% of the patient had a flat anterior chamber or the hypotony. And it's quite a big number. But flat anterior chamber usually, but not always, accompanies the hypotony. How do we define the hypotony? Various studies have suggested different numbers, but this is most commonly that I use for my patient is if IOP is less than 6 millimeter of mercury, that could be defined as a hypotony. In another word, the pressure that causes the secondary changes in the eye structures like retinal maculopathy or swelling of the optic disc, or the folds in the choroids, or the swelling or the folds in the cornea. In some patients, hypotony can be a detrimental thing, giving us a severe hypotony maculopathy, which may reduce the vision, even at the pressure of 8 to 10 millimeter. But the other group of the people who has a pressure very less, even 4 millimeter or 2 millimeter, but still they are working very well. So for us, clinically significant hypotony can be defined as the condition where the IOP is low enough to cause the visual loss or the blurring of the vision. Now for shallow chamber, we have to grade. If it is a grade 0, means the chamber is shallow, but the endothelium is not in contact with or touching any part of the uvea in even the periphery. Grade 1 suggests that there is a peripheral touching, but the chamber is still formed everywhere else. If the chamber is between 0 grade or 1, we just observe this patient carefully. We monitor them and call them frequently, maybe every week thereafter. Grade 2 is where the endothelium is touching up to the mid periphery, up to mid iris, but not the pupillary border. And grade 3, the endothelium, lens, and iris, they all are touching each other. It is almost flat chamber. So grade 2 for us is very important because the patient may go to grade 3, which has a bad effects, and it is a medical emergency. You have to reform the anterior chamber immediately. So this is how we bifurcate the various early post-operative complication. I will be talking only the hypotony with the flat or shallow chamber, which could be there because of the leaking bleb, overfiltration, or the choroidal effusion. The leaking is already been discussed. I do the Siddle test even on the day 1 or every follow-up, at least up to the 1 month follow-up. And the leaking could be from the wound edge, or it could be buttonhole, or you have to observe whether patient has an ideocorneal touch with the shallow chamber. And usually the patient has a deepening of the chamber by the 7th or 14th day. So you can have a conservative management for some time. But if there is a corneolenticular touch, we have to be aggressive in the treatment. As I said, if there is a patient has a visually significant symptom, we have to intervene, because there are so many bad effects of the leaky bleb. Could be patient may develop endophthalmitis or immediate risk of bleb failure if there is a flat bleb, which is because of the persistent bleb. And the choroidal effusion could be another sequelae. Now, hypotony with the overfiltration, overfiltering bleb could be there. It is usually it is benign in the course. Rule out any treatable cause is there. If the persistent hypotony is there, it may lead to the hypotony maculopathy, which is reversible till 5 to 6 months. After that, it cannot be reversed. So initially in early phase, one can use autologous blood injection in the bleb or bleb compression sutures. I am doing this a lot when it is required. And sometimes surgical management in form of resuturing or bleb reconstruction with scleral patch graft may be required. So this is how I bifurcate the management for conjunctival leak, or start with the reducing the frequency of the steroids, give pressure patch, large corneal diameter contact lens is very useful, and fibrin glue or the surgical repair. For overfiltration, again, reduce the dose of steroid, pressure patch. Atropine works like a wonder by pulling the iridocorneal lenticular diameter backward and large diameter contact lens and surgical repair. The reformation can be done with the viscoelastic or air or the gas. Choroidal effusion usually resolves spontaneously, and here also one can start the oral steroid and the topical atropine and drain if there is a lenticular touch with the cornea or kissing choroidal, or there is a prolonged hypotony and no sign of improvement with the conservative management. I would like to share the case of mine, a young male patient who had a primary open-angle glaucoma and was on the treatment in right eye, and left eye had surgery done for trabeculectomy with mitomycin C. And on day 1, everything was fine. The picture is shown here. IOP was 7 millimeter of mercury and well-formed bleb, and CDL was negative. Wound was okay. So patient came back with the discomfort, pain, and red eye on the 5th day. And when we found out there was a shallow chamber with the cells and flare in the chamber, and there was a pigment dusting on the endothelium. The bleb was diffuse, non-elevated as shown here, and wound appeared to be well sealed. We did the CDL test and we found out it was positive in this patient. You can see here, there was a small buttonhole of 1 to 2 millimeter size, and that was leaky for this patient, which was 3 millimeter away from the limbus. So option available are shown here. So we selected to put a large BCL of 14.5 millimeter diameter, which covered the hole very well, and enhanced the treatment with the prednisolone more frequency. Patient was already on moxifloxacin and cyclopentolate.
Just 1 minute left.
The leak disappeared. Everything was fine. We removed the BCL and patient did well, chamber well formed, and the pressure was also. So conservative management does work whenever it is possible. Then this is a case of overfiltration. Large cystic bleb was seen, and there was a very shallow chamber in this patient with the choroidals. So what we did in this patient, I did the compression sutures. It was taken with the nino nylon, and it was done with the horizontal compression suture with the, this is on day 1. And after 1 month, you can see nicely compressed bleb. Patient had an IOP of 14 and was well formed. And this is another case where there was a maculopathy also. It was a late case of the overfiltration. So multiple compression sutures were taken in this particular patient. So overfiltering is already been discussed by previous speaker. So this is also one of the late case with the thin cystic large bleb. And you can see the very thin layer of the conjunctiva on the bleb. So conjunctival advancement with the hooding was done, and this is 30 months post-op picture. and the IOP was then maintained at 10 with a stable visual acuity. And last case where there was a seen cystic bleb, and you can see the obvious scleral melt in this particular area. It was a cystic leaky bleb. So the bad necrotic conjunctiva was removed and the scleral patch graft was done and the bleb was repaired. And lastly, sometimes we may have an aqueous shutdown because of the increased inflammatory response. And in that case, one has to use a large dose of steroid. Even when you suspect that this eye is likely to develop this, start with the initial topical as well as systemic steroid. Thank you very much for your question.
Thanks, Dr. Dr. Mayuri, for a wonderful talk, and so much of information was packed in 8 minutes. Now, a question to the panel. We know if it is overfiltration, you see the IOP in single digit. You see a shallow anterior chamber and an IOP in double digit. Would it be an overkill if you start suspecting malignant glaucoma too, or should that be also be one of the diagnoses? Shallow anterior chamber with IOP only in double digit.
So, so I think that, it's very important to keep that suspicion in mind, provided that, you've taken a look at the bleb and there's no obvious bleb leak or anything like that. I think it's very important because malignant glaucoma it's not only associated, with significantly elevated intraocular pressure. Sometimes you can have pressures, in the normal range, and yet you could be having malignant glaucoma.
Yeah.
So I think Vinay is absolutely right. And we have actually seen a couple of patients like that, and he's absolutely right. So the pockets start forming over there, and later the pressure may just suddenly jump. So one has to be very, very clear and careful about that. Very, very nice question, Chitra.
I think you have to look at the configuration of the anterior chamber and the relationship with the ciliary body, iris, anterior chamber, because there's a filtering fistula. So in the initial phase, the IOP may be low because there's some aqueous is getting shunted out through that. But when the healing happens, the pressure is going to go up because the area is going to scar up, and then the pressure is going to go up, and you have flat AC and lens RS diaphragms. So I think recognizing that is important. So that's true. There's sometimes malignant glaucoma can have low IOP, at least in the beginning.
Murli, can you take a question?
Chitra, can
Yes.
I say?
Yes.
Okay, so one very interesting thing, because we just had a couple of these hypotenuse patients, either ours or referred from somewhere. And like Mayuri with a wonderful presentation has already said everything, but by and large, what I want to say is that even beyond 6 months, sometimes you can wait. And we have had patients whom we have done at 9 months and even 1 year, where there was a hypotonic maculopathy, but the trick is that you do an OCT and you check if the undulations inside in the OCT, they are not getting attached to each other, then you still have time. But if they are getting close to each other, then the retina chap told us that yes, now if you wait for any longer, then I have to do internal clearing as well. And then once you show to the patient, they'll be ready for getting a patch or whatever you want to do as a repair.
So I'd just like to add, there is a challenge with the definition of what constitutes hypotony in terms of, and I think it was alluded to during the talk. So for us, if the intraocular pressure is a little bit low, we would just routinely do a OCT actually. And if we find choroidal folds, that is an indication for us that maybe we now need to think of doing something for the patient to increase the pressure actually. Because if you leave the choroidal folds for any significant length of time, then there's a very high possibility of patients developing an epiretinal membrane actually. So, that is how we would look at a patient. So our definition is a little bit fluid depending on the presence of choroidal folds actually.
Yeah, so that's exactly what I was trying to say.
Yes.
You have to keep looking at the OCT. And you're right about the pressure. I have so many patients who have got 4 millimeters pressure and they are 6/6 vision for years now.
Yeah.
Yes.
I said in the beginning, Harsh, for some eye, it is okay to have a hypotony.
No, absolutely. You are perfect. I'm just trying to tell this to the students, that.
Last patient, I showed you the multiple compression suture. He had a severe maculopathy. And in spite of doing everything, the vision cannot be recovered.
Yeah.
I just have a question.
Yeah.
When you remove the compression suture, and the second, how often do you do a choroidal drainage for CD? I mean, it is a rare event, but even so, it is not a never event. It sometimes you may have to do it. What's your approach?
It's for me.
Yes.
Okay, madam. I don't do many cases of choroidal drainage. It's rarely required. Most of them usually respond well with the conservative management.
Yes.
Unless it is hemorrhagic choroidals and high IOP, in that cases the drainage is required.
Yes.
In many cases.
So we have done a couple because there was somebody referred to us and one-eyed patient vision down to 2/60 and they are starting to get a kissing choroidal. In those kind of situation, one has to go 5 to 6 millimeters behind. First open up, repair wherever,
Not through the past plana.
and then you go out and then you go in and make a small pocket over there. But that mostly are retina people do.
Okay. Because earlier we used to do through the pars plana, and because it's always a ciliachoroidal detachment.
Thank you. We go on to our next speaker, Dr. Vineet Rathra, who is again a senior consultant from Medical Research Foundation, Chennai. And he's going to be talking to us about how to prevent and manage common complications of aqueous drainage devices. On to you, Dr. Vineet.
Yes, madam. Thank you. Thank you for Dr. Chitra for the invitation. And thank you, ARC. So I'm going to be talking about prevention and management of common complications of aqueous drainage devices. And I'll mainly be talking about the MS glaucoma valve because that's what I generally use. I have to thank Dr. Vansh, our PG. Sorry. And also Dr. Soumya, a former PG who's now doing her glaucoma fellowship in Canada. So I won't go into the indications of what, when we need to do a glaucoma valve, but I'll just go into the different steps of the MS glaucoma valve and where, what we can do to prevent these. So the first is a traction suture. One could take a partial thickness traction suture through the cornea using a spatulated either 8O or 6O suture. The complications one could get is that cheese wiring, which is more common than a full thickness, in which case one needs to take a bite a little deeper. The other option is a superior rectus suture, which is optional but doesn't give as good visualization as one does with a corneal suture. The second is the peritomy. You want to do either a fornix-based, a near fornix-based, or a limbal-based. It's preferable to do the first surgery in the superior temporal quadrant because the surgical access is easier and there are lesser motility disorders. One needs to remove dissect at least 90 degrees. It's good to balloon the conjunctiva with a 30 gauge needle with saline. Dissect the conjunctiva, the tenons, and do a little cautery. Don't over cauterize because that would increase the fibrosis. The next step is priming of the MS glaucoma valve. This is with injection of balanced salt solution, 1 cc, with a 30 gauge cannula through the tube. You should see the BSS coming out of the valve in a steady stream. You should look for absence of resistance and a free flow. Don't over prime the tube. Don't manipulate the valve mechanism because this could damage it. The next is to anchor the plate. This is done around 8 to 10 millimeters posterior to the limbus. One needs to mark the muscles, identify the muscles, mark the position of the implant using gentian violet. There is research in progress on the use of antimetabolites to decrease the fibrosis there. And then suture the suture with either suture the plate with either a 9O or a 10O suture. Care must be taken not to damage the muscles and avoid any part of the flange of the tube going under the muscles because this can lead to post-op diplopia. So that's what one needs to take care of. Also, this is a little thinned area of the conjunctiva. One can perforate through. This is the possible complication, especially in patients who have euphthalmos or collagen vascular disorders. One could also have a cheese wiring, which can cause plate migrations. The next step is doing the anterior chamber entry. It's preferable to use a 22 or a 23 gauge. One can bend the needle at 100 degrees. This is so that it follows the contour of the globe. One needs to look outside to judge the trajectory and then go onto the microscope to determine the plane. In certain patients, especially phakics or those with angle closure, one would need to do gonioscopy to determine the iris configuration, and in these patients, one may need to do a goniosaniculisis. So once this is done, I like to form the anterior chamber with viscoelastic so that the anterior chamber and the tract stay filled with viscoelastic. So the size is important, otherwise one could have a leak in the immediate postoperative period. So just do a 22 or 23 and don't cut while you're coming out. Have a single entry, avoid multiple internal tracks because then your tube can go in various planes. The anterior chamber entry should be parallel to the iris. It should not be too anterior. This could damage the endothelium. Don't make it too posterior because this can cause a persistent uveitis due to the iris chapping and touch. The next is trimming of the tube. This is by holding the tube with a tooth forceps and then trimming such that you have around 2 to 3 millimeters of the tube inserting into the anterior chamber. If it is too short, it will retract. If it is too long, you can have an endothelial touch. One would cut it at around a bevel of 30 degrees so that you can facilitate the entry. So here I'm trying to push it. It's not going in the first time. So you need to come out. If need be, reform the anterior chamber and then push and see that the tube is entering into the anterior chamber. So if you're doing it in the anterior chamber or the pars plana, you need to cut it with the bevel up. If you're doing it in the sulcus, one needs to do it with the bevel down. Otherwise, the iris tissue can block the tube. Next is to anchor the tube. You need to anchor it with a trapezoid compression suture. You could use the same 9-0 that you've used to anchor the plate. This helps stabilize the tube and it prevents the hump-like protrusion of the tube under the graft, which will reduce the risk of graft erosion and tube exposure. Next is covering the tube. This you could use various donor materials since access to cornea and sclera is easiest to us. That's what we use. You need to trim and suture. It's around 6 to 6 millimeters. So you want to make it partial thickness, not too thin, not too thick. If it is too thick, also the comfort is less. It can, with lid movement, one can have an erosion of the graft. You need to cover it close to the limbus and anchor these graft along again with a 10-0 or 9-0 suture. There have been sutureless variants which have been described using tissue glue, or one could also use a long scleral tunnel or under a scleral flap. For closing the peritomy, do remember good conjunctival opening is key to a good closure. So if you're just doing a phonics-based incision, you can use wing sutures. I like to do it 2 to 3 millimeters away, and then use absorbable sutures, either 8-0 or 10-0, and close them in a continuous interlocking fashion so that you have a watertight closure. If you're doing a limbal-based incision, you need to close them with a single or 2-layer closure. And most important is at the end of surgery, you need to check, see if there is a physiological pressure, check the anterior chamber depth, and one could use fluorescein and also check if there are any conjunctival leaks, which one would need to close. About the postoperative complications, there are similar types of complications in both the major studies that we have seen. I'll talk just a few of them. One is hypotony. Most of the valves are, the Ahmed valve is designed to prevent postoperative hypotony, but one could still guess if one is doing over priming or excessive manipulation of the valve housing. So one needs to avoid that. If you make too big an entry with a 23 gauge needle, one can get the aqueous humor egress from there. And certain patients can have a ciliary body shutdown. Those are those patients who are at risk. And choroidal effusion, which we will manage as we have already discussed, either observe them, use steroids, and if there are kissing choroidals, one would need to drain them. The elevated intraocular pressure, This is, you can have it in the early stage where there's blockage of the tube with viscoelastic, fibrin, iris, and blood. So YAG is a good tool here, which one could use. If not, and if there is, one needs to wash, one can go in and then wash it away. In the hypertensive phase, it generally occurs between the first 1 to 6 to 8 weeks. It generally peaks within 1 to 2 months, and it's because of the capsular fibrosis around the end plate, which decreases the permeability of the aqueous around it. It generally resolves at around 6 months as the capsule reorganizes and becomes more permeable to aqueous. So if you just have a hypertensive phase, one needs to just tide over it, use aqueous suppressants. You can think of a digital massage, but do remember that in these tubes, one can end up with an endothelial touch. Now, in some patients, you can have late intraocular pressure rise. That is when greater than 6 months, when it would be a failure. If it's because of an encapsulation, one would need to do a needling with 5FU, or a surgical revision. One will have to dissect the conjunctiva and excise the cyst wall. The next important complication is that of a tube exposure. It's seen in around 1.5 to 2 years, and is percentage is around 2 to 7%. More common in patients who have a limbal stem deficiency like aniridia. We do know it can increase endophthalmitis, risk of endophthalmitis inflammation. Whether you use a corneal graft or scleral graft, none of these have a difference in the graft survival. If you have a functioning valve with no infection, one can re-anchor it and patch the graft. In this patient, it was a young lady who had significant scarring, so we had to do it a little temporal. And at the first week, she had an injury by her small child who hit her eye, and there was a gaping of the wound of the conjunctiva. So we placed a scleral patch graft over here and covered it. And this is the lower two photos are those which are nearly 4 years. Subsequently, she's undergone a cataract surgery and her pressures are well maintained. So the general rule is if edges of the patch graft are covered by the conjunctiva, then healing generally occurs by the migrating corneal epithelium. One can identify by looking at the conjunctival capillaries over the tube, and also 1 to 3 millimeters from the corneoscleral junction. If there is loss of these capillaries, then you will think that this patient can go into a tube exposure. This generally occurs because of immune response. When it's a high immune response, when it is within the first 6 months, can occur also because of the mechanical rubbing of the tube. Generally, if it's more than 6 months, it's because of a patch melting or a low-grade immune response. It's more common if it is inferior, if the GDD is inferior as compared to superior. The corneal complications, this is around 9 to 27%. Why it occurs? Because of the tube, the exact mechanism is unknown. Is it because of the hippus, the flow which is caused by the heartbeat, the inflammation, or is there a corneal endothelial touch or a foreign body reaction? It could also occur because of ocular causes, that the patient has had high intraocular pressures for a long duration of time. You've had a traumatic surgery, or just changes in the aqueous humor composition. The anterior segment OCT is a good way to determine. If it is, studies have shown that if the tip of the tube is close to the cornea, you have greater loss of endothelial cells. Infection, recurrent blebitis is an indication for the shunt. It is very rare because of the grafting material, mainly because of the conjunctival erosion and tube exposure in patients who are at of a young age. Diplopia and strabismus is common. This could be because of trauma to the recti or because of the silicone flanges of the tube under the muscle. One could use prisms, or very rarely these patients may actually need a strabismus surgery for the intractable diplopia. And thank you for your kind attention.
Thank you, Dr. Vineet. That was a thorough talk and truly informative. I have a question for Dr. George here. If the IOP is high over the few weeks and the tube lumen is patent, so how do you deal with it?
I think Dr. Ratra had already alluded to that in the topic. That is, if you have a hypertensive phase, almost always we just have to tide over it with aqueous suppressants. I don't think we can, unless otherwise the capsule becomes very thick in an Ahmed glaucoma valve over a period of time. Needling hardly ever works. And very, very rarely you might have to go in and excise a part of the capsule underneath the conjunctiva. But it's very difficult to deal with these when you don't have an obvious cause which we can see in the slit lamp and address.
Murli, can you take any question?
It's better to start them on, prophylactically, you can start them in anti-glaucoma therapy and, therapy. Say you have to choose a IOP threshold for yourself, like is it 12 or 15 millimeters of mercury. Anytime the IOP goes beyond in the early post-operative period, I think that's an indicator the IOP might go up further. So put them on anti-glaucoma therapy prophylactically and keep that on for several weeks, I would say, until the capsule has matured. So I think that also works.
That's extremely important. Every Ahmed glaucoma valve, from day 2 post-operative, if pressure is 10 or above, we usually keep them on a fixed drug combination in an Ahmed glaucoma.
Yeah, I find that is about 12, 13 millimeters of mercury. So once the IOP is 12 or 13, I kind of tend to put them on.
Yeah. Can I just say something, in spite of putting patients on the drops, we've still had the development of encysted blebs. We still had pressure not coming down to where we wanted it, And so I think there are some patients, we get the sense that, even in spite of putting the drops, the pressure continues to rise and you're not able to get over the hypertensive phase. The hypertensive phase actually, isn't transient. It just tends to become permanent with a thick walled bleb, And then whatever we have tried, it just hasn't worked. Actually,
it does happen. It does happen sometimes. I think I think there are many other factors which actually cause the fibrosis. So some people fibrose more naturally than others. But I think one of the factors is the IOP itself. So when you have a closed cavity, there's a fibrous capsule there, and the pressure is high. So that's kind of causing a stress, the mechanical stress on the collagen, which is around it. So the fibroblasts, they produce more collagen in that area because there's a stress there. So if you're reducing IOP, at least you have taken care of the one factor. But there are other factors, of course, and some people would fibrose in spite of whatever you do. So the idea is just to reduce at least one stimulus by fibrosis.
I totally agree with what Dr. Nagia said. Sometimes it's very refractory, and it occurs over a period of 4 to 6 months it takes for things to settle down, and we need to have a lot of aqueous suppressants during that phase.
I have a question. How many use antimetabolites?
Once in a while, I have used in cases which are already kind of a buccal already put there. There's a retinal surgery has been done, especially with the buccal, a lot of fibrosis. So I do use mitomycin C once in a while, but it's not routine with me.
There is a paper that has come out saying that intra-op and post-operative injection mitomycin has increased the function of Ahmed glaucoma, though I personally don't use it because I don't feel comfortable having mitomycin in an area where there is so much of hardware going in.
Would you have any question before we go on to our next?
Yes, I had a question for the panel. How do you do needling? I mean, needling or bleb excision when the Ahmed valve starts to fail, and how early have you done it?
I think I don't do needling. I think if the body failed and the capsule is really thick, I have done excision of the capsule a few times. So you just open it from the interior edge and you remove the entire, whatever you can remove the entire capsule and suture the conjunctiva back. So that will give you an IP control because there's a valve there, so there's no risk of hypotony because the valve is still going to control IOP. But invariably, the fibrous capsule comes back again, a few months later.
How early can we do that? How early?
Only needling hardly ever works in an bleb encapsulation. It hardly ever works.
So I just want to tell you, we've struggled with this, and we punctured the bleb, often because when you puncture the bleb, it's fantastic. All the fluid gushes out, and the pressure falls down. There's a sense of relief, but almost always it's, and then we said this capsule is very thick, very tough, can we do something else? So actually we made multiple, linear incisions with a knife actually in the bleb. And to our horror, within a few days, it all healed up actually. And it was all back to...
Even if you remove the entire, whatever you can remove, say, you can't remove the whole thing, but if you remove half of it, let's say, physically cut it off with the scissors and it's very thick, sometimes it feels like you're cutting sclera, it's so thick, and it comes back again. So there's a problem.
So just one unrelated point. I really want to reiterate, and I think George was asking me that last time in some another meeting, that especially inferior valves, please cover the entire tube with the sclera, because the chances of infections in inferior tubes are much higher than in superiorly placed tubes.
Thank you. Thank you very much. We go on to our next speaker, Dr. Preeti Kamdar, who's a young glaucomatologist from Mumbai, who's going to talk on another very important topic, managing the late complications of trabeculectomy.
Thank you, Dr. Chitra. I'll share my screen.
Yeah.
Thank you, Dr. Chitra and team ARC for the invite. Am I audible and my
yes.
And my screen can be seen? Yeah.
Yes.
Okay. Thank you. As has already been said by Dr. Kirti, that a glaucoma patient is yours for life and he can never go off follow-up. So now there are some complications of trabeculectomy, and most of these can be because of the bleb and its functioning. There are few like cataract and aqueous misdirection and other ones which are not very common. So what helps me when I have these long-term problems, whenever there are functional blebs which are problematic, okay, functional blebs, I tend to categorize them into one of these four, all right? And I have also tabulated the surgical options which are necessary. So these has helped me decide what I should do when, and I will just elaborate on it. One thing is that these are long-term complications. So most of the times medical management has already failed or these occur later. So most of them, they require surgical management. So let's come to the first one. That is a large bleb with symptomatic hypotony. Now this is a person whom I had operated in May 2022. Until November, he was doing very well, pressures of between 10 and 12. But then this, if you see this bleb, it has become a 360 degrees bleb. Not only that, but he developed symptomatic hypotony, means the IOP went to 5, and he developed choroidal folds, which decreased his vision. So it needs to be treated. Now, how you treat it is, you can have two options. In November, I did try, when this happened, I tried again atropine and steroids, but it did not work. So now what am I left with? One is that there is no conjunctival problem. The sclera seems to be okay, and the intraocular pressure is low. So I need to suture, means reinforce the scleral sutures to reduce the outflow. So basically what I need to do is reduce the outflow. Now there are two ways of reducing the outflow, or one more way, which Mayuri madam showed very well, using compression sutures. But the other methods are, one is you actually open the conjunctiva, go underneath and take scleral sutures, or what you could do is, but when you do that, you are exposing the patient to bleb failure. Whenever you touch the conjunctiva, you have to explain bleb failure. But what has worked very well for me is transconjunctival sutures. So transconjunctival sutures, the risk of bleb failure is minimal. But you need to prepare before that. On pre-op, what do you need to ensure? You need to ensure that you are able to make out the scleral edge, the flap edge, before you can take that. And second is, you have to confirm that there is no scleral melt underneath. So what you can do is, on the slit lamp, take this Hoskins suturolysis lens, press on this conjunctiva, because this conjunctiva has an elevated bleb. You're not going to see underneath. So you, for 15 seconds, you blanch the conjunctiva, and this is what happens. It plasters the conjunctiva to the sclera for a short time, and also blanches the blood vessels, and you can make out the edge of the scleral flap, and you can also see that there is no underlying scleral necrosis. Having done that, having ensured, now you go ahead for surgery, and on table, here I have sort of blanched, sorry, okay, just switch off the, this is, all right, you blanch off the conjunctiva, and make sure this is under topical, but I have also reinforced it with preservative-free lignocaine. When you go underneath, you have to make sure you are not touching the blood vessels, because if it bleeds, it's horrible. Now I have blanched it with this forceps, but you can use the Hoskins lens, Etuate, or there is a disposable Hoskin lens which can be used, and it works wonderfully well, and it's not as expensive. It's only 5,000 or 6,000 rupees. Now, if once you have taken the patient on the table, if I feel one suture is going to be enough, I usually take 2 or 3. And why is that? Because it's so easy to undo the, if you feel that the filtration is less and you have overdone it, it's very easy to undo it. All you need to do is, now these sutures, conjunctival sutures, they will sort of migrate into the conjunctiva. Any point of time you want to release the sutures, you have to remove the sutures. It's so simple. Now this is one suture which has sort of buried itself into the conjunctiva. So on the slit lamp, with Paracaine, take a plain forceps and try to pull out just a bit of the conjunctiva. It's very easy. And once you do that, now go in. Yeah, I have done that. One little bit of the suture is, I have made it accessible. And then go with a 26 number needle and just cut it off. And once having done that, you can use digital massage or whatever you need to enhance filtration. So this is what has worked very well for me. And how can I prevent this? Others have already said this: tighter sutures, use releasable sutures, slow sequential release. I had done all this for this patient, but still I got this problem. And this is the way I handle it now. This is a Bleb with nuisance value. In the sense, it is not thin-walled. It is just high. The intraocular pressure is wonderfully controlled between 10 and 12. So here I don't have overfiltration. And so this, I have decided I'm going to just compress, mechanically compress the a Bleb. And this poor lady, like, she has a very symptomatic cosmetic blemish. And all the time she complains, okay, my eye looks horrible, but she has yet to consent to the compression suture. But this is, when she consents, this is what I'm going to do. Now, these are the real troublemakers. This is a very thin-walled Bleb. There is a Bleb with a leak. And here is a Bleb which is multiloculated, thin-walled, all of the above. I mean, it has all the problems. And this is already, the bottom one is one which already has blebitis. So now here these Blebs, no matter what the intraocular pressure, no matter what the patient says, you have to resect the bad conjunctiva. You have to resect this part of the conjunctiva, reinforce the sclera if there is scleral necrosis, reinforce the conjunctiva by putting and pulling fresh conjunctiva, and then resuture it. So these have to be addressed as soon as possible. This particular patient where you have the scleral necrosis, he just did not allow me, he did not agree for resurgery, and he's the one who landed up with an endophthalmitis. I mean, that was a really bad, so I now more aggressively counsel, but sometimes they don't agree because they say vision is good, pressure is good, because I have to counsel them about Bleb failure when I'm touching the patient. So that is one problem. So now this is just match the columns. What I showed you earlier, what you can do, how it helps you in decision making. Now there is sometimes you have a hypotony without a large Bleb. And usually if the patient has not had hypotony in the early post-op phase, it is mostly because of a micro leak or because the patient has rubbed the eye or whatever. But very occasionally it is because of mitomycin toxicity It's not overfiltration. No matter how much of a patch graft you put, how much of the sutures you put, you are not able to correct the hypotony. And if it is symptomatic hypotony, it's really a very sad, difficult position to be in. Now, failing Bleb has been dealt with in detail. This is how you recognize a failing Bleb, and that is by telling the patient that you have to follow up. That has to be drilled into his mind. One thing I wanted to just re-emphasize, that a failing Bleb, you can try and revive it, maybe 1, 2, 3 years of surgery also. Time is not a factor in telling a patient that maybe let's try to revive your original Bleb. Now, encysted Bleb is a problem which has all the disadvantages of a Bleb without the advantage. Usually an encysted Bleb is associated with an elevated intraocular pressure, and it responds well to needling, beta blockers, and massage. If it recurs, if the situation recurs 2-3 times, then maybe you can resect it and draw fresh conjunctiva. It may help. So cataract, now I don't consider it as a complication of surgery. It is just a side effect of surgery. One thing is, earlier I used to tell patients that, okay, if I'm after cataract surgery, there is a chance of Bleb failure, but I no longer sort of emphasize on it because of the minimal inflammation after cataract surgery. Aqueous misdirection as a late complication of only trabeculectomy, I have found it equally in patients who have not undergone trabeculectomy or just a cataract surgery, and also in patients. So it's equal, the incidence in whatever I have seen. But however, it is, how do you diagnose it? How do you suspect it? It is easy in pseudophakic patients. It is easy in open angle glaucomas because the AC will shallow. But in a patient who has angle closure, it is difficult to, unless you have a very high index of suspicion, you're going to maybe label it as a failing Bleb. And so that's why aqueous misdirection as a late complication is difficult to diagnose in angle closure. The treatment remains the same whenever it is done. Now, Swan syndrome and these other, it's not a very common complication, but it is like blood vessels which bridge the ostium, and they intermittently cause bleeding. And there would be some very rare ones which you will see once in a lifetime. So in a nutshell, what I wanted to say is that follow-up is necessary. Glaucoma patient is yours for life. How do you prevent all these problems? You lower the MMC concentration. Earlier, I used to use 0.25. That means diluted by 8 ml. Now I use 0.2. I never have used it for more than 2 minutes, and use it over a larger area. Releasable sutures have added so much to my comfort zone. Do not rub the eye. The patient should be constantly told, shown that this is what is there. There's a fistula there. Do not rub the eye. Thin-walled Blebs repair as soon as possible. So this is, thank you all for a very patient listening. I will stop my share screen.
Thank you, Preeti. That was a wonderful talk with beautiful surgical depictions. Wonderful. So is there any small role of in the late leaky Bleb scraping epithelium? Is there a small role of in the late leaky Blebs scraping the epithelium, overlying the Bleb and advancing the conjunctiva? That does not help at all, because that was one thing you didn't cover. So I just wondered.
Sorry.
The Bleb sparing epithelial exchange, which Dr. Dada had described, is there a role for that? That's what.
Dr. Dada, I wanted to take that question with him, but he's not there. I think she's covered it all. Dr. Harsh?
Chitra, I just want to thank you from the bottom of my heart. I have learned so beautifully 3-4 points today that it is so wonderful, you know.
Wonderful. The joy of learning from all this.
You can every time you learn, every time. So beautiful. And Preeti, thank you so much because we all know all these things, but the moment you see them so beautifully done, you want to do them again.
Thank you. What we liked was the great clarity which you had and the way you subdivided it in your talk. And wonderful.
The subconjunctival suturing was really very nice.
Very nice.
But Preeti, you have tried some of my laser things. I wish you in that 360 degrees, you had tried that laser technique in which I painted the bleb, and on either side, if you do the gonioplasty spots over there, I have had many patients in which we were getting away with doing nothing else but just the laser part of it.
Okay, I'll try that, because this is a patient who refuses. Since 2 months, I'm trying to convince him. He refuses, it took me a long time to convince him.
They don't mind sitting on a laser.
Exactly. Yeah, they don't.
That is why I said
Yes.
that it is a
Yes.
simple thing to do.
Yes.
Even if it fails, there's nothing to lose.
Right. Yes, sir.
So we go on to our next speaker, Dr. Renuka Srinivasan, who's a professor from the Pondicherry Institute of Medical Sciences, and she's going to be telling us, dealing with failures in trabeculectomy, how do I make my next move? That's a tough talk. On to you, Dr. Renuka, to make it as interesting as possible for us.
Thank you, Dr. Chitra, and thanks to the members of the ARC for giving me this opportunity, and good evening to all the panelists and the members who are watching online virtually. And I've been, there is a bit of an overlap with the previous speakers. The topic is failed Bleb. What next? What can we do next? Surely, as somebody said, glaucoma patients are ours forever, and sometimes they haunt us. And this is one such instance that they tend, that it becomes quite difficult. And nonetheless, trabeculectomy, which was described by Keynes way back, continues to be the gold standard for glaucoma surgery. However, with good preoperative risk stratification and meticulous intraoperative technique and watchful postoperative care, we can reduce the risk of failures, which is said to be around 10% per year. Bleb failures begin to show up right from day one postoperative, wherein it is heralded by hyperemia, vascularization, and rise in intraocular pressure in the first month. And the bleb is smaller than required. It may get encapsulated. Then there can be the characteristic ring of steel, and also finally a frank flat bleb. Certain factors predispose to failures, and all of us are aware of it. These include anti-glaucoma agents, which induce hyperemia and prime the conjunctival and Tenon's fibroblasts, thereby promoting healing or promoting fibrosis. Neovascular glaucoma are not the best patients because there is release of angiogenic substances and fibroblastic growth factors. Prior violation of the conjunctiva with tissue scars, as in cataract surgery and trabeculectomy, also predisposed to failures. And the case of secondary glaucoma from uveitis triggers fibrosis. Young age patients with their thick tenons and excess inflammatory reaction are also prone to failure. Some patients with ICE syndrome have a tendency for the endothelial cells to proliferate onto the sclerostomy. The block in the sclerostomy can be in many areas. It could be in the epicleral membrane. It can be in the form of a tight scleral flap or a transscleral fibrosis or an internal fistula membrane. Interventions in bleb failure, there is no consensus. It also often depends upon the experience and the expertise of the surgeon, but most surgeons would follow the following kind of guideline. In the early stage, it is important to suppress inflammation with the use of topical steroids in high frequency. The steroids are not so much for the uveitis as for reducing the wound healing. And in the proliferative stage, one can resort to suture lysis either with laser or releasable sutures along with steroids. And of course, digital massage. The role of digital massage has not been proven in very large studies, but they are quite useful in the early stage of postoperatively, especially in the first few weeks, 3 months to be precise. And after that, it may be of less use. In the maturation stage, one has to resort to 5FU, subconjunctival, or needling, and continue with bleb massage. And in the final inactive stage, one often does mitomycin C with needling and or revision of the bleb. So this is a releasable suture which has restored the bleb. Now, bleb revision should be done with minimal trauma and involves exploring the site of the fistula, opening the scleral flap, dissecting the scar tissue, and finally restoring the communication. So this can be done. So what is the evidence for the efficacy of revision? There are not many large studies. The one from Moorfields on 100 patients has shown that the IOP reduced from 26.5 to 15 with an average of 1.6 needlings. And at the end of 1 year and 3 years, 55% and 75% and 52% had untreated intraocular pressure of less than 22 millimeters, respectively. So anyway, this is worth a try because it's better than a second surgery. So most often it is done, it can be done ab interno with the gonioscopic aid, and then with the use of a sharp needle, the fistula is entered from inside, and the bleb is teased, or with side-to-side movement, the tissue under the scleral flap is released and the bleb restored. The other approach is the ab externo, which is commonly done. Here, with the help of a needle or a bent needle or a Ziegler's knife, which is introduced about 1 centimeter from the region of the fistula. It has worked its way under the conjunctiva into the scleral flap, and then teased with blunt with side-to-side movements, and the scar tissue is again released, and until the bleb is seen with the opening of the fistula. So once, if these methods fail, often these are used along with mitomycin C. If this fails, and if the bleb is frankly scarred or encapsulated, one has to do an excision. And this can be done again by opening up the original wound, and then dissecting the encapsulated bleb, exposing the scleral flap, and the original scleral flap, and going under the scleral flap and releasing the scar tissue, and then the wound can be closed in the regular fashion. So this is the bleb, ring of steel, which has restored the bleb. Now, bleb revision is not without complications, because it has all the complications of primary trabeculectomy, naturally so, because dissecting the tissues is quite challenging, and there can be more scarring and further bleb closure. Atrophic areas and scleral grafts defects may require a patch graft during the process, and more the manipulations, more the inflammation, and more the scarring. And there is small danger of entry of drugs like MMC into the antechamber, which should be watched for and washed out. And infection, cataract, and all the other complications are even more possible in a second surgery. Now, this shows the recurrence of the failure can recur, and after a few months or a year. And then once these procedures have been tried, maybe sometimes even twice or thrice, one has to resort to repeat surgery. And most often, most popular procedure is repeat trap with MMC through a virgin site in the conjunctiva, maybe a little temporal. And nowadays, the glaucoma drainage devices are getting popular after the tube and strap study, which has proven that this may be a better procedure for a repeat. And depending on the situation, one can do a combined trap with cyclodialysis, or one can do PPV with glaucoma drainage device, especially in pseudophakics. And you can also have a end-stage glaucoma can be treated with cyclophotocoagulation. And to conclude, modern trap, it continues to be the gold standard, but late failures occur 10% per year. Careful preoperative risk stratification and meticulous intraoperative technique, watchful postoperative care can reduce, if not eliminate, failure rates. Mitomycin C and 5-FU are useful adjuncts which reduce the risk of failure. And interventions like bleb needling, revision, and excision are options and alternatives to repeat surgery. Finally, repeat surgery includes trabeculectomy, GDD, cyclophotocoagulation, which are the common options. Thank you very much.
Thank you. Thank you, Dr. Renuka Srinivasan. That was again A very informative talk. Thank you very much. Dr. George, I have a question for you here. Dr. George is there? Yeah. Now, is there any role for doing a second trabeculectomy, or would you, the first one fails, you would go on to doing a glaucoma drainage device?
There is sufficient evidence in literature saying there is a definite role for a repeat trabeculectomy, especially if the first trabeculectomy has worked for for some time, at least for 4 or 5 years. But it also depends on a lot of other factors like the health of the conjunctiva. Each time you're repeating a trabeculectomy with mitomycin and it fails, then again sufficient conjunctiva may not be available for your glaucoma drainage device. That is one thing. But still, I would say there is a definite role for a repeat trabeculectomy, provided the first trabeculectomy. But suppose the first trabeculectomy has scarred very, very, very soon, probably in 3 to 4 months. There's a lot of conjunctival fibrosis. Patient is on a lot of anti-glaucoma medication, further compromising the health of the conjunctiva and also compromising the success of a repeat trap. Probably you would have to tilt in favor of a GDD as your second surgical option.
If you're going to do a second trap, would you change the concentration of MMC, which was used in the first case? That is your first case. So it's not been a referred case. You know you would have done your best for the primary trap and it has failed. And you didn't expect any problem to have happened, but it did happen. So in that case, what would you do for your second trap?
Unless it's a very high risk of failure patient like a neovascular glaucoma, I wouldn't alter my concentration or the time duration. I stick to a standard of 0.4 milligram per ml for 2 minutes. That's what we do routinely.
Yeah.
But I would
one needling, or would you try even 2 needling before you decide on a second?
Absolutely, you can repeat the needling. Absolutely, if there is evidence of subconjunctival scarring and provided your ostium is totally free, there is absolutely no harm in repeating the needling.
Yes.
So can I just add something?
Yes, yes.
You know, if you have a myopic patient, actually, where the healing is not very good, and especially if it's a myopic patient where, you had taken a decision to use mitomycin and it didn't work out, then these are the patients where very late needling, tends to work because the sclera has been very thin. So it's never healed properly, actually. And of course, I agree with George that, depending on what the vascularity of the conjunctiva is, sometimes you get late, you get Bleb failures, and it's been quite some time, and the patient comes to you for first time, depending on, how much the conjunctiva is stuck and, the vessels over the conjunctiva. That would be an important decision maker for me as to whether I would go again for a needling or not, actually.
But how early would you needle before we go on to our next talk? Would you try digital massage? But with the digital massage, the conjunctiva is, you realize it's not very mobile. Would you go and do a needling even by 3 weeks?
So there are 2 things about massage. One is that if you massage and let the patient wait in the clinic and you check the intraocular pressure between 60 to 90 minutes, if the pressure comes back to normal, then you know that your massaging is not going to work. The next step would be that you teach the patient to massage, which used to happen in the era before mitomycin, and see whether that's going to help. And if that doesn't help, then I think I don't have a timeline for that. I shouldn't do the needling at this point, actually. If I feel that, the fluid is not flowing out and the intraocular pressure is rising, and of course, you still have to do laser suture lysis or releasable sutures if you have that. If after all that, it hasn't worked, then, I would go ahead and do the needling, actually.
Yeah. Thank you very much. Murli, if you have a question, or shall we go on to our next?
Madam, I have a question for Dr. Davinder Grover, if he's there. Dr. Grover, are you around?
No, we have to inform him, and
Okay.
I'd rather you inform him before Dr. Purvi starts, because I might forget.
Okay.
We go on to our next speaker, Dr. George Putran, who I've already introduced, and he's going to tell us about how to deal with failures in aqueous drainage implants, how to anticipate, minimize, and move on. On to you, Dr. George.
Thank you very much, Chitra ma'am, once again for the opportunity, and I hope my slide, so this is the World Glaucoma Association guidelines to report on surgical trials, like surgical failure in GDD. They have defined either due to inadequate intraocular pressure control, or due to hypotony, or a reoperation for glaucoma, or a complication, or loss of light perception. I thought I will use this 8 minutes to just go through some practical tips in each of these situations. So inadequate IOP control, common because formation of a very thick capsule, and more commonly with the valved implant. And as we had discussed earlier, probably it is more prudent to use a non-valved implant, especially in the young age, because of the larger surface area. It predisposes to a thinner wall, lower profile, larger surface area blebs. And again, aqueous suppression is vital. Usually the hypertensive phase in the non-valve implant is a little more delayed than in a valve implant, because the inflammatory cytokines, the pro-inflammatory cytokines in the aqueous immediately reach the capsule after your surgery in the valve implant, while it takes about 6 weeks. By then the anterior chamber would have quietened down, and probably the aqueous is not as inflamed as it was in the initial postoperative period. And this is probably the reason why the hypertensive phase in non-valved implant is a little more subdued and more amenable to medical treatment. But as I was mentioning earlier, aqueous suppression is vital, immediate post-op in the valved implant. And even after the suture patency, the tube patency is re-established, after the auto suture lysis in your non-valved implant, we still continue aqueous suppression to bring down the incidence of hypertensive phase. Coming to hypotony, it's extremely important to avoid peritubular leakage. The tubes have to be snug fit in the tracks you fashion. Again, temporary complete tube occlusion is vital in non-valved implants. We used to use now every non-valved implant, every RD that goes in gets an intraluminal stenting with supramid intraoperatively. And I'm very happy to say that Aurolab has finally commercialized this. This is freely available now in the market. This again has huge potential. The sudden decompression of the eyeball when that your vicryl suture gives way is avoided because of the 3-0 supramid in the lumen of the tube. Coming to reoperation for a complication, I will briefly go through these hypotony, tube exposure, tube cornea touch. So again, we have found this 3-0 supramid. Chronic hypotony is sometimes very rarely it occurs in a non-valve implant, but it occurs very late and it is an unexplained hypotony. And this has been well described in literature. Again, the 3-0 supramid has become a real boon to reverse hypotony in these chronic hypotony patients. And it's extremely easy to push in your supramid into the tube lumen, and there is a definite tamponading of the flow, and it acts as a wick for the aqueous to flow into the capsule. Before the supramid was available, it was so difficult. We had to go in through an ab externo approach, and we used to use 3-0 nylon monofilament. The supramid is multi-filament, so it really sticks to the tube. And this was a case where before the supramid, we tried an ab interno 3-0 nylon monofilament. So it is a very strong message that always for ab interno stenting of tubes for hypotony, we have to use the multi-filament supramid. Almost always tube exposures occur within 4 millimeters from the limbus. It doesn't occur much beyond that. And burying the tube in the patient's own sclera has a definite potential to decrease the incidence of tube exposures. Again, whether it's the right eye or the left eye, the scleral tract is positioned medial to the original position of the tube. And this way, the tubes tend to enter the eye close to the 12 o'clock position. It minimizes the contact with the upper eyelid, and so again has a potential to decrease the incidence of tube exposure. We have also incidentally found out that the sinuous route that we took, see, this is a tube which is very close to the endothelium, and we were able to reposition this tube to a much deeper position in the anterior chamber without a tube extender because there was adequate length of the tube still available. Coming to tube cornea touch, see, this looks very innocuous. It looks as if it's absolutely fine. But if you see carefully, if you put a slit on the tube, the slit that is created on the tube is very close to the cornea. And there is sufficient space between the slit on the tube and the iris. Again, here, there's absolutely and invariably these kind of patients initially have some form of focal corneal decompensation, and ultimately these become near total corneal decompensation unless you intervene sufficiently early. Coming to that, tubes need to be as far away from the endothelium right from its entry site. So again, as I was mentioning, see the space between the slit on the tube and the slit on the cornea, and right from the entry site, and there's hardly any space between the slit on the tube and the slit on the iris. This is an ideal position and has a maximum chance of long-term corneal survival. Again, to re-emphasize, see the distance. This is very close to the tube, the cornea. This distance is, and this is something which we need to avoid. How do we avoid? Usually we see that it's beyond the scope of this talk, but usually we find that if you dip into the anterior chamber at this particular point, it's either between the 2.8 and the 3 millimeter, you are usually able to maximize the distance of the tube in the anterior chamber. But depends also on the preoperative anterior chamber depth. Suppose the anterior chamber is shallow, we might have to go in further and dip in. If it's a nice pseudophakic depth, this 2.8 millimeter would get an ideal position of tube in the anterior chamber. Just a very small video edited just to show how tricky tubes can be in the pediatric age group. So we are fashioning a 4 millimeter long 23 gauge needle generated scleral tract to guide the tube into the anterior chamber. So this is what I was mentioning. So that is where we decide to enter the 2.8 millimeter. We decide to enter. Everything looks like as if it is going fine. It looks as if you are at a good distance away from the cornea in the anterior chamber. Also, we have also found that this 23 gauge needle tract makes needle generated tract is a snug fit for all glaucoma or glaucoma drainage tubes from different manufacturers. So now the tube is threaded in through the scleral tract. And because, and as soon as we see the entry in the anterior chamber, if you see carefully, it's entering the anterior chamber very close to the cornea. We cannot be leaving tubes in the anterior chamber close to the corneal endothelium, and especially in the pediatric age group. We have to fashion, these tracts are self-sealing, and we have to fashion another tract. And here we can adjust the position of the dip of the needle so that we get it further posterior to the initial tube position. Again, the 23 gauge needle. See, there before it reaches the 2.8, we have decided to get into the anterior chamber, and ultimately we are able to get the tube a little more posterior, sufficiently posterior, so that it's well away from the endothelium. It's also extremely important while coming out to have as less of aqueous egress as possible, so that the anterior chamber is well formed. The tube is repositioned into the second track. A good bevel also helps in easy threading of this tube into the anterior chamber. In children, the scleral rigidity is very variable, and however much you try to position these tube as close to the iris as possible, there is an elastic recoil that happens, and the tube ends up very much much more anterior than what you would routinely expect. So the lesson here is it has to be perfect at the end of the surgery. Even if it is perfect at the end of the surgery, we can expect a few complications. So there is absolutely no chance if you leave it close to the endothelium, and especially in the pediatric age group. This is another small edited video which shows that you can route tubes into the anterior chamber where there is sufficient depth available. This patient had a significant, which you will see at the end of the surgery, had significant anterior PAS. So you can aim with this particular method of scleral track with the 23 gauge needle. You can position tubes in places where there is adequate chamber depth available, so that the tubes are as close to the iris, and also increases the chances of long-term tube survival, corneal survival in these patients. So this is an aphakic eye with significant peripheral anterior synechiae probably at the initial site of surgical incision for the cataract surgery. So this is what I was mentioning. Even if you're placing your plate in the supratemporal, you can route these tubes into the anterior chamber. And see this. This is the distance from the corneal endothelium is sufficiently more than what it is near the iris. The important thing here is to trim the tube exactly the distance you are trying to relocate it to medially. So suppose you want to place it 3 millimeter medial, you trim it 3 millimeter anterior in the original position of the tube, you get an adequate 2 millimeter length of the tube in the anterior chamber. Again, in one of our recent papers, we have also said that we have also recommended that in the very young, as the eyeball grows, we probably need to target 2.5 millimeter to 3 millimeter length of the tube in the anterior chamber as close to the iris as possible during initial placement, unlike in adults where 1.5 to 2 millimeter length of the tube in the anterior chamber would suffice. And this is my last slide. Just re-emphasizing the importance of placing the anterior edge of the episcleral plate has to be positioned 9 to 10 millimeter posterior to the limbus. This is anecdotal. We have seen most of the complications due to glaucoma drainage surgery occurs either due to very poor conjunctiva, which we are dealing with, or because the plates are positioned very anteriorly. Thank you very much.
Thank you very much. Wonderful talk, Dr. George. Murli, would you want to take a question? We have 2 more speakers, just 1 question allowed.
Yeah, sir, I wanted to ask you regarding the supramed suture. Do you have a video showing how exactly you do? Do you do it in every case, the supramed stenting, and leave it subconjunctivally so you could yank it out later? Or
yeah, every patient, Murli, I will share it with you, and if I get a forum, I can also share it. Every patient gets in the 3-0 supramed, and it's become so much safer, because otherwise at that 6 weeks, I'm sure Devinder will also agree with me. Otherwise, at that 5 to 6 weeks post-operatively, when that autolysis occurs, anything can happen. The eyeball can suddenly decompress, choroidals can happen, shallow anterior chambers. And after we have started using supramed in every patient, the surgery has become so much safer. And usually, in many of the children, supramed just stays there subconjunctively for months together.
And do you remove it if the pressure drop is not adequate?
If the pressure drop is not adequate, definitely we will remove it. I haven't removed a supramed before 7 weeks post-operatively. You have certain, you can see, look at the edge of the anterior edge of the episcleral plate. If it's very prominent with supramed in place and with pressures are high, you will have to remove the suture. But if you have a nice bleb forming over the plate, even with the supramed in place, you can afford to leave it for some more time.
Thank you. We go on to our next speaker, Dr. Purvi Bhagat, who's the Associate Professor and Head of the Glaucoma Department at MNJ Western Regional Institute of Ophthalmology, Ahmedabad. And she has an interesting case situation for us to discuss, and that would be followed with Dr. Grover's case. Yes,
thank you, Dr. Chitra, for this excellent academic session right now. So I'll be discussing this nightmare case of a male who is 37 years and is a medical teacher in one of the nearby colleges. he was diagnosed as having juvenile open-angle glaucoma at the age of 15 years, that is in 2000, and having moderate glaucomatous damage. In the past ophthalmic history, after 1 year of diagnosis, he got both eyes trabeculectomy done outside. From 2019 onwards, that is 18 years after the trap, there was a rising trend of IOP in both the eyes, and there was a gradually escalating medical treatment that had to be started for this patient. In 2021, there was right eye sudden onset of small hyphema, which resolved with routine conventional treatment, that is topical loteprednol, eye drops, and atropine eye drops. He had a history of pulmonary tuberculosis in 2011, for which an AKT was done and complete resolution was achieved. In 2020, he suffered from COVID positive, for which systemic steroids were given for a long time and in heavy doses, and he was found to be a steroid responder around that time. Following this, he developed again a further rise in intraocular pressure, both the eyes, but left eye was reasonably managed with all the topical drugs, but right eye was not responding to the treatment. So we operated, so then the patient was referred to our center, being a tertiary center, and finally we operated for right eye retrap with MMC. All was again well for 1 year. After that, in 2022, we had to operate him for right eye cataract surgery, and this surgery was as uneventful as any other cataract surgery that you would do. And the binocular vision was achieved of 6.9 in the right eye and 6.6 it was there in the left eye, and N6 with correction. So you can see these pictures also. This is the left eye, and this is the right eye, clear cornea, AC is normal depth, and a good pseudophakia. In October 2022, another episode of a sudden idiopathic onset of small hyphema occurred in that eye, the same eye, right eye, but which again resolved with routine treatment. But that is not all about the case. The nightmare actually began for us then after October, and in fact, it is still continuing till date. So this is the IOP chart that the patient himself has formed. You can see all these documented applanation tension readings with the visual acuity times and all the treatment that the patient has been taking. After October 2022, he has the cyclic changes in intraocular pressure. If you can see, the spikes have been going as high as 57, 40, 42, 46, and 40. So we have to put the patient on full medical treatment during those episodes. Following that, the IOP starts to slope down each time, but then ultimately it ends up in the stage of hypotony. So you can see here it goes as low as 4 millimeters, 4 millimeters. And yesterday only we had seen the patient and the IOP was 2 millimeters of mercury. The anterior segment each time you see is almost as good as normal, only that in the stage of hypotony, you can feel that it is digitally very soft, but the corneas otherwise are clear. The AC is neither deep nor gets shallow when it is in a hypotonous stage, it stays the same. And posterior segment, when it goes into a state of hypotony, it drops to 4 and 2. It does show changes of hypotonous maculopathy. There are choroidal folds, and twice he had also developed a choroidal detachment. Left eye, if you see, this is with 4 topical drugs that are there. This graph is almost quite well maintained, and the IOP just ranges from 12 to 16. That is the range that the patient has. And in spite of giving the patient acetazolamide and glycerol during the spikes, there is no similar drop or hypotony that is happening in the left eye. And these peaks and troughs of both the eyes also do not correspond with each other. So it's just the right eye that shows this cyclical changes that happen. This is a case of OCT. We have done lots of OCTs. Each time he ends up into hypotony, and you can see this typical macular changes that are there. So there is no diurnal variation which we can pick out. The changes just keep happening randomly over time, over weeks and over months since then till date. The Bleb is diffuse, it's mildly elevated. Unfortunately, I don't have all the pictures. The ostium is open. We also did the UBM and ASOCT. The iris configuration, if you see, it's absolutely normal. The IOL is well in place in the bag, and ciliary body is well in position, no synechia and no cleft, nothing. We did a uveitic profile also. Everything is normal. For the hyphemas, we did the Doppler, prothrombin time, lipid profile, HbA1c, everything is normal. It's just that the Mantoux test is positive, but of course, considering the past history of AKT, this is actually bound to happen. So till date, after the cataract surgery, we have not been able to have a good balance of the intraocular pressure. On one side, it goes very high beyond 40s and 50s when we have to treat with maximum medical therapy. On the other side, it goes into a stage of hypotony when we have to treat with soft steroids and atropine each time. And the visual acuity overall since then is still maintained to 6.9 and 6.6 in that eye. Only when the patient develops maculopathy or develops a choroidal detachment, the vision drops down to 6.18 or 6.24. But again, the moment it resolves, it comes back to 6.9 and 6.12. So in this ARC webinar, I just want all these international stars that are there listening to this case presentation to guide and suggest how to bring an end to this nightmare that we are facing.
Thanks a lot, Dr. Purvi. I just wondered whether an antiviral titer could have been done also, because that microhyphema which happens, which is suggested, just done. Makes me wonder, because we've done everything. That was also done, huh?
Yes, that was also done. And he being a medical teacher, he is also very apprehensive, and he also does a lot of research, and he also keeps us suggesting this test to do, that test to do. So
Puri, what happened to the fields?
Fields, because of constraints of time, I did not put up all the data and pictures, but fields are maintained. They are, I'd say, a superior arcuate and inferior arcuate, and there's no split.
Despite the cyclic changes, there's no change in the fields.
No changes in the field since the time he presented to us, and same in the left eye.
Is he following any yogic practices, or
No,
is he
sir.
doing a water drinking test on himself every day, following Ramdev?
No. That also, sir, we inquired. No.
Is he having sleep apnea?
No, sir. And otherwise, he is perfectly fit, healthy, and young, active individual.
That's a very interesting case.
So that is why I thought so this is the best forum.
I know. I have one case. I mean, not exactly the same, but he would respond very dramatically to carbonic anhydrase inhibitors. So whenever we give him, so when the pressure is high, we would give him a carbonic anhydrase inhibitor, and the pressure drops down to almost 5-6 millimeters of mercury. And when you stop, then we stop anti-glaucoma medicine, the pressure goes to in the 30s and 40s. And subsequently, we realized that this was happening because of carbonic anhydrase inhibitor. So we removed CIA from his treatment and treated with other things, and then the pressure was better stabilized. So are you carbonic anhydrase this patient by chance?
I don't know.
Yes,
but you have done all the tests for uveitis, no?
Yes.
And the thing is, glaucomatocyclitic crisis?
No evidence. No
evidence. No, you would have
clinically no evidence of any inflammation also.
Bosner-Schwarzman also can present without any evidence of uveitis.
Yeah.
But
and it's
the
very
trend
difficult.
is continuing since
The patient has undergone filtering surgery with a good Bleb.
Yes. And the cyclic changes are happening since October. So it's practically now 5 months. So that up and down is going.
And this started happening after cataract surgery.
Yes.
Anywhere the haptic of the lens is UGH sort of a syndrome in the UBM?
No, it's absolutely in the back, no touching anywhere. And as I said, no clinical.
There's no rubbing of the iris, even if it's in the back.
No. And this onset of hypotony, this sudden spontaneous, even had before the retrab was also done. Before we operated for trab and the cataract also, he had one episode of spontaneous hypotony. And the patient is so meticulous and aware. He himself has prepared that graph. When I told him I'm going to share your case, he said, "Madam, I'll prepare this graph for you." And so that entire line graph the patient has prepared himself with all the dates and time points.
What Dr. George says is the only possibility which remains.
Why should an hyphema occur? No, why should an hyphema occur spontaneously? There has to be a reason.
Some underlying cause.
Yeah.
Bleeding the tendencies which because
we did the prothrombin time and platelets and everything, that is normal.
And also
hemophilia or something, hemophilia or some such.
And I think could it be like a
can't be that. He underwent 2 trab surgeries. He would have had the issues there.
And I don't know whether we should investigate for an ocular ischemic syndrome also.
Could it be a acute heterochromic uveitis? Because
carotid Doppler has
they can have a spontaneous hyphema. And also they can behave a little abnormally when the IOP is concerned, because when you have a little, there's a subclinical inflammation going on there. You may not see obvious KPs, or they're very fine KPs. I think but is there an evidence to say the patient had a fixed heterochromic uveitis? Now, fixed uveitis, they call it nowadays. So I think maybe
no,
look for that
no
as well.
excessive pigment dispersion, no heterochromia, that is also not there. And carotid Doppler we had done to rule out any such vascular component, but the Doppler study is also normal.
Just one thought. It
No,
may not be
no
the,
transillumination defects also
No,
any.
no, the hyphema may not be related to the ups and downs of the pressure, but the hyphema, as I just mentioned, that Swan syndrome, where you have small blood vessels growing across the ostium. So just check for that. So I don't think hyphema is related to the ups and downs. Yes, I don't think so.
But would that blood clot in the or blood vessels in the ostium, would it cause a hypotony?
No, I don't think it's related to that. The hyphema I'm trying to explain, that there might be these micro vessels growing across the ostium which bleed
She has to get this patient treated.
Yeah,
So
that is the beauty. That is the beauty of glaucoma, ma'am, because with so many glaucoma specialists in this forum, Dr. Purvi, I don't think has reached anywhere as far as the solution.
Let us try the international star. Let us ask Dr. Grover.
Yeah, he's quiet. I think he has the answer up his sleeve.
Yeah, I'm in the middle of clinic, so I missed her presentation. I'm sorry I missed it, but I'm just in summary, I'm getting a sense that this patient has recurrent hyphema after a phaco-trab.
And spikes and troughs of IOP. Yeah.
Is this a one-piece or a three-piece lens?
Single piece acrylic
Single piece.
preloaded.
You know, and you've done the UVM because sometimes the haptic can poke through the capsular bag. The other thing I've seen is the patient had an iridectomy with the trabeculectomy.
Yes.
And was the sclerectomy or sclerotomy, did it involve Schlemm's canal?
Yes.
Okay, so what happens sometimes is you can get blood reflux from Schlemm's canal if it has if the sclerotomy has involved Schlemm's canal. So if the pressure goes down, it can get blood reflux through there, and then you will on gonio. You can see some abnormal tissue or some blood vessels there. You know, one thing you could try. Does it come out with any behavior when he bends down? Does it bleed?
No. In this entire episode of glaucoma that he has had since 2000, this has happened only twice. And one time it was before the first trap, and the second time it was before the second trap.
Okay. Sometimes what I do in clinic is I try to bring it out. So I'll either, press on the eye or have them bend over and then do gonioscopy and see if you can find it coming from somewhere. But, the answer with all these situations, in my mind, anytime I have a challenging case like this, is you first have to look to where the doctor has been. It's usually something that when I see things like this, it's usually something that I did. And when you intervene on a patient and there's a complication, we have to make sure we rule out all the things that we do, because it's almost always related to something that we did to the eye.
No, what is the explanation? It's not
Purvi,
the hyphema.
no, Purvi, I think
it's the
Chitra,
IOP side.
I think what Pandav has said is very, very right. I think next time you stop just one drug, since you are giving almost everything, and then the things go down. So you can actually not give CAI one time, and one time you may not give PG unlock or something like that. And just try and figure out, is it a drug reaction which is suddenly lowering the whole thing?
Yes, that can be tried. Because the moment it goes to 46 and 50 and
you put on everything.
Yes.
You tend to give everything.
Develops halos and everything, so we start everything.
So don't worry, because the fields are still stable.
Yes. The acuity and fields are maintained, so it's just the
no
IOP
panic.
Coming to hyphema, I mean, do you get spontaneous hyphema in your GAT patient, or when you remove the trabecular meshwork?
Recurrent hyphema?
Yeah.
Yes.
Or spontaneous hyphema, because you had
I have seen that. I had a patient who was a yoga instructor, and anytime that she did downward dog, she got a hyphema. I have one patient after a goniotomy, not after a GAT, but after a goniotomy, that will have random spontaneous hyphemas, and I have her sleeping elevated. on a couple pillows forever now. You know, sometimes what happens is these patients, when they sleep, they will, especially if they, you know, they sleep on their face, they'll sleep like this, and they press on their eye, and they can induce elevated episcleral venous pressure and cause a hyphema. So also, whenever these kind of situations, I will, I'll ask about the sleep positioning and how they sleep, because sometimes they press on their eye and they don't realize it in the middle of the night.
Can you start your case so that we get totally muddled when we end the day?
Yes, yeah. Okay, so mine, thankfully, is not a diagnostic dilemma, but it's more of just a challenging case, and again, where my patients have taught me something. And I have no shortage of these, but this is just one I thought was fun. So this is a patient with persistent hypotony. He's had angle closure glaucoma, had fornix-based trabs done in 1999. He had a arterial occlusion, central artery occlusion in the right eye, and has a dense cataract in the right eye. His Tmax was as high as 68. I first met him in 2009, and you know, his vision in his left eye, which is a good eye, was 2100. Pressure was low, more in the left than the right. He's cytonegative, but he had these pale blebs, ischemic pale blebs, and has some evidence of hypotony maculopathy. He's on steroid twice a day. He lives far away. He lives over 100 miles away, and it's very hard for him with his vision to get in. And so he comes in, and he comes whenever he wants. And so this is what his macular OCT looked like in 2018. And then he's been stable. He was stable for a while, and then he kind of was just happy with his vision and didn't want anything done to his good eye. And then he comes to me and says, "Hey, I'm leaving even further away." And he, you know, in Texas, we have a lot of very rural areas where patients, you know, they live 300 miles away from anybody, and they don't have access to care. And he was going to live on a farm, and you know, I was hesitant with him being this far away with this pale ischemic bleb, especially with the hypotony. And he's like, "Well, can you do something to help me improve my vision?" So, so I did at the slit lamp. I did just some mattress sutures, horizontal mattress sutures, to see if we can help improve the vision and compress the bleb to get some higher pressure. His pressure went up just a little bit, but his vision didn't change. And he was in the process of selling his house and everything like that. And he comes in, and 4 months later, and now he has a bleb leak, and it looks like he might have leaked around one of my compression sutures. And so then I have a concern of him leaving far away without proper care with this pale ischemic bleb that is now leaking. And so I did what's called a plug and abandon, and I'm going to show you this video. You can get a sense. I don't have any clinical pictures, unfortunately, but you can kind of see what it looks like. So you can see, and I'll rotate his eye down. But those are all my, I did some vertical and mattress 9/0 nylon sutures that kind of compress things. But you can see that he has a pretty pale ischemic bleb. So I take him back, and he's leaking through there. I think he's leaking right over here. And there's a little opacified. So I take him back, and the first thing I do is I try to take out all the stitches, and you can see with these eyes, they bleed. No, you touch them, anything, and they bleed, because it's a little inflamed, and the tissue is not healthy. So I took out the stitches, and then I just need to kind of, in these situations, I did a traction suture. I'm going to make a very broad-based peritomy. You can't really, I'm going to test his conjunctiva, but he has a good amount of scarred conjunctiva. Sometimes you can hood these and, dissect and then bring the conj forward. He did not have healthy enough tissue to bring it forward. And then he had this big defect. And so what I did was I made a very large, you can see anytime I touch it, he bleeds. So I made a very large peritomy, 5 to 6 clock hour peritomy all the way around it. And and further past it. And then I'm just, dissecting around. And then, you have a lot of bleeding. You have this elevated bleb. And you really need to make a big pocket because you need to mobilize as much tissue as possible. And you can see he's leaking right here. He's leaking right here. But the key thing is you use this cautery to shrink and melt the tissue so that it lowers down, and that's going to be easier to close. And then you also destroy all the epithelial tissue. Right. If you don't destroy the epithelial tissue, the tissue won't heal, and you have a persistent leak. So I can see he's leaking from right about here still. And I'll put a couple of sutures through there, but then I'm going to use a piece of pericardium. So I'll put some sutures through there, and then I'm going to put a large piece of pericardial tissue. And I like pericardium. It's not cosmetically appealing, but I like pericardium in this situation because it's a sponge. It's almost like Tenon's tissue. It's a sponge, and it really allows you to get a watertight closure. And this is 9-0 nylon. And so what I'm doing is I'm going to form it around the bleb. I'm going to cut it to an appropriate size, fixing it to the limbus so that we have a nice watertight closure. And then I'm going to trim it. And I'll trim the anterior lip, and then I'll trim the posterior tissue to really get a nice closure. And then once you get closed, then you reform the eye, and you need to make sure it's watertight. Okay, you really need to make sure that the eye is pressurized. I pump up the pressure at about 25. The eye is pressurized and it's watertight. And so now the question is, well, what do we do? And sometimes with these eyes, there's still a leak. And there's still some flow. We don't really know what's going to happen. And so what I did here, Dr. George gave a nice talk on his strategy for tubes, and with the IDE implant, it's a 350 implant similar to the Barvelt 350. This is what's called a ClearPath 250. So it's a single plate implant. So it doesn't involve muscle isolation. I can do this under topical anesthesia. There's more and more data coming out that the size doesn't really matter, that whether you get a 350 or a 250 millimeter squared surface area, that you still get about the same pressure lowering. But the safety outcomes that we published for this implant, the 250 implant, is so much better because you're not putting it under the muscles. You're not even having to isolate the muscles. So the rate of double vision is significantly lower. The rate of persistent hypotony is lower, and the patients are much more comfortable. But I didn't know what his pressure was going to be. So Dr. George was talking about using his technique, using the SupraMid and having it protect the opening. I don't like the tube opening on its own at all. I like to be in control of when the tube opens. So what you can see here is that this is a 7-0 proline suture with the wings longed, and then this is a 4-0 nylon suture. This tube is closed forever until I pull the suture out. So I have complete control over when the tube opens. And sometimes I don't open the tube for a year. And I can tell you that when you open the tube 3 months out, 6 months out, a year out, the patients do so much better because the eye is quiet and calm, and there's not a pro-inflammatory aqueous going out. So I'm putting in this 250 ClearPath in the superior temporal quadrant, fixing it to the globe, putting the tube in here. And in the US, we still use corneal patch grafts. And I could have used some of the pericardial tissue, but I think actually cornea is a little bit better for covering the tube. And I like to make my tubes a little bit longer. And so this is partial thickness donor cornea. And then I affix that over the tube. And then this is the 4-0 nylon attached to a needle. Now I'm tucking that suture in the inferior fornix and bring it through the conjunctiva. And so it's going to sit there. And I'll cut it long right now because when you're manipulating it, it can get dislodged. And I'll adjust it later. So I'm adjusting it so that the suture is not going to be in the way. And then I tuck it away from the tube. And then I close the conjunctiva. And this is another challenge, right? Because now the patient doesn't have a lot of conjunctiva. So I'm closing the conjunctiva and mobilizing as much as I can, fixing it to the sclera, using atovicro. I don't fenestrate a lot because I don't think I can close my conjunctiva and I don't want to leak. So I actually don't fenestrate a lot at all, if any, because I don't want it to leak. And then, you know, I have this, I reapproximate the conjunctiva to the pericardial tissue and suture it as much as I can. And you know, reapproximate as much as I can. And what I like about pericardium is you can suture to the pericardium. So, you know, so I'm bringing it back, even this posterior tissue, I'm moving it forward and fixing it to the pericardial tissue with partial thickness bites. And, you know, at the end of the day, it looks like this. And it's watertight. It's watertight. They have bare pericardial exposed because there's no conjunctiva at all. The tube is in good position. It's not opened at all. And then I can be done. And this tissue, the epithelium will grow over that tissue. It's not a problem to leave that exposed like that. In time, it will epithelialize over. So, you know, it didn't go away completely. When you have long-standing hypotony maculopathy, sometimes you still have some folds, but his folds did improve. You know, his vision improved a couple lines from 2100 to 2060, and his pressure went up to 16 to the point now that I actually had to put him back on timolol. Now his tube is not even open yet. His tube's not even working. The suture is still there under the subconj space, not exposed, and that suture can be opened at any time. But he's no longer at risk of blebitis. He can now move and go anywhere he wants. If his pressure ever goes up, they can start drops. And if he ever needs the tube activated, he can come see me, and I have complete control over when we open the tube. So this is a technique I use sometimes, and this is actually now my standard way of doing tubes, tying it off with a 7/0 proline with a 4/0 nylon ripcord. And in a normal eye, I'll fenestrate a lot to get the pressure down. And even if their preoperative pressure is 35, I'll fenestrate a lot. Now you have to close the conjunctiva the way you would close a trabeculectomy. You know, I close it with 9/0 nylon and make it very careful and close it very watertight. And sometimes my fenestrations work 3 to 6 months, 9 months, a year. And it's really improved safety for my patients. And my rate of double vision has gone down and my long-term success has gone down. And we're going to report on our data. I'm just working on the paper right now on our 2-year outcomes, 3-year outcomes for this patient and for this case, this type of technique. I hope thank you for your time, and I welcome any thoughts or questions.
Wonderful case, a lot of food for thought. Wonderful, Dr. Grover. It was like hearing a nice story.
Yeah.
Dr. George, you have anything to tell?
Only a few observations, Devinder. One is that we don't have access to tuboblast, and if we have to use cornea or sclera, I think it's not possible to leave it exposed like that. Usually the eye just rejects the sclera or cornea which is not covered by conjunctiva.
You have taken conjunctiva from the inferior fornix and
that also usually the eye rejects it over the second.
George, we have had a couple of cases in which this was a little exposed and it did well. So I don't think that the rejection comes automatic over there, and I was happy that he was able to tell that part.
Yeah,
yes, Dr. Hans, yeah, that if you have at least a part of the whatever graft you have covered with at least around 2 or 3 millimeters of conjunctiva, it tends to epithelialize and grow over. Yeah. Especially if you have either sclera, cornea, or pericardium. It generally tends to.
And the second observation I wanted to share was the mindset among us is on seeing a patient like this is probably most of us would take care of the hypotony alone first.
Yes.
And then probably take care of the glaucoma later. I think that's the difference, and that's the difference between the Western world.
Yeah. Very right. Very right.
Yeah.
Very true.
Yeah, it's hard because you need to shut it down, right? And this is his only eye, And if there was not enough tissue to cover it in a safe way, and he's already had one case of blebitis. But the problem is if you shut it down, you're at very high risk for a pressure spike. And then going back and doing something for a glaucoma is going to be much more challenging. Dr. Chitra, you mentioned taking the conjunctiva from below. So the technique that we've used, because when you do a full thickness autograft, you're basically cutting away all the vessels. And the problem with these eyes is their vessels aren't healthy. So if you take the tissue from below and cut it all out and then move it to the top, you've then lost your inferior quadrant, or you've damaged your inferior quadrant. And then two, sometimes that tissue just dies because there's no blood vessels. So what we've published on also is something called a pedicle flap, which is a rotational flap where we keep I've done rotational flaps from an inferior to superior and keep that intact. And then you are maintaining a blood supply and bringing in new blood vessels. And maybe next time I can talk about that technique. But I would strongly discourage you from doing a complete autograft because you need those blood vessels. And bringing healthy blood vessels is key for fixing some of these problems. But yeah, whether it's pericardium or I have patients where there's not enough tissue to close it, and I have to leave their bare sclera. I rotate the conj to cover it, and then we leave a bare sclera available, and they do fine, and they will epithelialize over as well. So I think unless it's a pro-inflammatory environment, usually the tissue doesn't melt.
Devinder, just one clarification. You had 4-0 nylon in the lumen, right?
Correct.
Yeah. And then you had a 7-0
proline.
Proline.
Yeah, so that's a permanent suture. That doesn't dissolve.
But still the lumen, the tube lumen is minimized, right? It's not the original.
Correct, but in one spot. And if you look at fluidics and Poissier's equation for tubular flow and resistance, it's related to the length of the tube and the radius of the inner lumen. And whenever I've spoken to physicists or biomechanical engineers that know about fluidics, they say when you just limit one small area, if I had made the whole tube that size, that would restrict flow because the radius, the length of the resistance is much longer. But in one specific area, when it's just a little bit squeezed tight, but still open, it doesn't really provide any resistance at all. So I haven't seen any limitation of flow from one area once that suture is pulled out.
And probably makes the surgery safer also.
Yeah,
the safety is that you open it 6 months later or 9 months later, and you've really given a lot of time for the capsule to form and for the eye to calm down, and then you have controlled opening.
Even when you open it becomes much more safer.
Yes, and then the patients come in my office, I open it, I stop the drops, I give them atropine, and I bump up the steroid. So it's not like, when it opens with a Vicryl and they're still on their drops and they come in and they didn't know it opened, and then they have choroidals and shallowing because the pressure is 5 and they're still on 3 agents. This allows me to specifically stop the medication or activate it. And for me, it's made my clinic and my life so much more peaceful and predictable.
Devinder, just one quick question. Don't you like doing inferior valves at all? Because one could have gone inferiorly here and we could have a safe conjunctiva over there.
I always, I try to save as many quadrants as possible, right? Because I know I need to plan for the next surgery. So in this situation, I was able to use that same quadrant in a safe way and not have to touch the bottom quadrant for maybe 5 years from now when he needs his next surgery.
Fair enough.
Yeah.
Thank you very much. I think it's been a truly wonderful webinar. I'm sure we would give 100 out of 100 for such a wonderful webinar today. And it goes without saying it happened because of such enthusiasm amongst the expert panel to get the stuff out of the speakers and the generosity in the speakers to put it all through in those 7-8 minutes which they gave to us. And thank you so much, Dr. Grover, for not only your first beautiful pearls which you gave us, but also this very interesting case, which actually told us more about how futuristic you are in your thought process too, besides just salvaging that moment. So kudos to you. Thank you very much, all of you. I need to thank the AIOS admin with Mr. Kripal and his team for the timely help they have offered, and to Sai and Manjula from Numerotech. And of course, I need to thank my own ARC team who are always there as my support system. I need to definitely thank, I think all of us, I'm sure Mr. Sunil, we have to thank Mr. Sunil for keeping track of the time and getting educated along with us. And we look forward to hearing from you, Mr. Sunil, as to how many watched this webinar. We'll be truly delighted. We would actually sleep with great contentment that many more learned along with us. And I think finally, I think I need to thank all the delegates for the kind of, messages which I received from them about how much they enjoyed the program, and how that keeps egging me on to come out with more and more webinars, besides the physical meetings, which we are doing a big way over the last 10-12 months. Thank you so much, one and all of you. I know it's going to be a late dinner, but thanks so much. Thanks, Dr. Grover.